switch on your cameras, and good luck to you all.
All right, can I start, Dana?
Yes, we can start.
Okay, thank you. So good morning, good afternoon, and good evening, depending on where you are joining us in the world. And welcome to the Symposium on Advancing Public Health Research, showcasing FETP projects and NCD-focused mini-grant initiatives. It's my pleasure to be here with you today. I am Dr. Rubassori, and I'll be your Master of Ceremony for this event. This one-day symposium highlights the diverse research contributions of field epidemiology training program residents and graduates across the Eastern Mediterranean region, along with a wide range of NCD's operational and implementation research projects led by awardees of the operational and implementation research addressing the burden of NCDs and the EMR. This event emphasizes on the importance of scientific writing and communication as a way to translate research findings into impactful public health policies and practices. So let us begin our program and let us hear more about the important work done by our fellow public health professionals. I'd like now to hand the mic over to Prof. Youssef Khadr, the Director of Center of Excellence for Applied Epidemiology here at EMFNet, to share with us his opening remarks. So please, Dr. Youssef.
Thank you, Ruba. You hear me, huh?
Yes.
Perfect. Distinguished colleagues, esteemed researchers, and valued partners. On behalf of Dr. Muhannad Ansur, the Executive Director of EMFNet, I'd like to welcome you to the Symposium on Advancing Public Health Research, showcasing FETP projects and NCD-focused mini-grant initiatives. This event celebrates our commitment to strengthening public health research and fostering collaboration across the Eastern Mediterranean region. Today, we highlight the impactful work of FETP residents and graduates and mini-grant awardees addressing critical public health challenges in infectious diseases, non-communicable diseases, and health system strengthening. The research is a testament to the role of applied epidemiology and operational research in shaping healthier communities. The symposium offers a platform for shared learning and collaboration with research that has the potential to influence policies and improve health outcomes. We hope these discussions inspire further action and inform the broader public health agenda. Thank you to all researchers, mentors, and partners for your dedication. Let us make this event a stepping stone towards continued progress in public health research. Welcome, and I look forward to a fruitful discussion. Thank you.
Thank you so much, Dr. Youssef, for these inspiring words. And now I'd like to hand the mic over to Dr. Carl Reddy, Director of DEFINIT, to share a few words with us. Please, Dr. Carl.
Thank you so much, Ruba and Dr. Youssef. You know, I cannot emphasize so well, greetings to all of you, and thank you for the opportunity to share a few words. And I really do wish all the presenters very well in their presentations. I cannot emphasize the importance of the characteristic. One of the salient characteristics of the FETP model is learning by doing. And the ability to write a scientific article and the ability to follow the scientific process in research projects is really the culmination of the training of FETP trainees, not only in the classroom, but also the important component of their field placement, which, as we know, is 75% of the time of the advanced program. More so, various countries in the region are in different positions of the epidemiological transition. Just imagine the epidemiological transition superimposed upon the demographic transition, and you know where the various countries in the region are on those set of curves. And hence, I think the importance of cardiovascular disease and other NCDs in the region in terms of the burden of disease, referring to morbidity and to mortality from NCDs in your region. It is also really important. You can do the best research ever with the most scientific rigor, but if there is no mechanism to disseminate the results of that research, then it doesn't seem to make any point. It doesn't seem to have any salient objective. And I must emphasize once again the importance of not only positive results of the scientific process of your research projects, but also negative results can also be very important. And a very important part of the training of FETP is the ability to clearly and concisely transmit the results of rigorous scientific inquiries, as you do when you conduct your research projects, transmitting these results to various audiences. We have communities who need to be informed about the results of an outbreak investigation to inform them going forward. We have healthcare workers that need to be informed of research that is done to influence their practice. Of course, there's politicians who have to be informed as well in order to influence resource allocation, as well as health managers who influence policy and practice. So the importance of combining your scientific process with dissemination of the results by presenting articles for publication and the scientific process in writing those articles and in conducting further research projects to answer the questions that are plaguing public health practitioners and health practitioners in your region. So once again, I wish you the very best in your presentations and in your careers going forward. And I cannot but overemphasize the importance of scientific writing and conducting research projects as the logical conclusion of the FETP training and the field placement. So thank you very much, Ruba. Over.
Thank you so much, Dr. Carl, for your insights, and it's our pleasure having you with us in this important event. So now let us hear more about the FETP Scientific Writing Training and the NCD Mini Grant Initiative from our Senior Technical Specialist at INFNET, Dr. Randa Saad. So please, Dr. Randa.
Thank you, Ruba. Ammar, can you kindly please share the screen from your end? Thank you very much. So, hello everyone. I'm Randa, and I've worked with most of you over the past year, at least, on some of these initiatives. And it's really a pleasure for me to be here to really provide an overview of what made this symposium happen, or the initiatives that whose results are now being presented during this symposium. Next, Ammar. So this symposium really focuses, as Ruba said, on two main initiatives: the FETP Scientific Writing Training and the NCD-Focused Mini Grant initiatives. And both of these initiatives were led by INFNET during the past year, with the main goal of really strengthening research, scientific writing, and the dissemination of information from this region to the world. Next. So let's start with the first initiative, which is the scientific writing training. During the summer of last year, 2024, INFNET conducted virtual training sessions under the theme of strengthening scientific writing skills. And really, the idea was to enhance knowledge sharing and the publication capacity of FETP residents and graduates. So we engaged residents and graduates, mainly from the intermediate and the advanced FETP tiers from more than 10 countries from the region in this training. And the training first engaged these participants in a self-paced online training and research methodology, and that was during the beginning of the summer. And this was directly followed by 4 live sessions during which the participants received structured guidance on really improving the manuscripts that they were developing. Next. Now, the impact of this initiative was remarkable, honestly. We received, after this training was completed, around 36 papers. So all participants submitted papers, and all of these papers were reviewed by a dedicated committee from within MFNET with some external participations from partners. And this committee really reviewed the manuscripts to ensure the quality and the readiness for publications. And as a result, many participants have now begun submitting their papers to scientific journals. And hopefully, in the near future, we will be seeing more and more of these papers in the scientific literature contributing to the literature available on public health from within the EMR. Next. And the second initiative, which I'd like to really provide you with an overview of, and this is an initiative that's dear to my heart, as my interest really is in NCD research. This initiative, which is the NCD Mini Grant Initiative, was launched under the title EMR Operational and Implementational Research Studies, mini grant opportunities. So really from the title, we were focusing on research that goes beyond descriptive research and really focuses on operational and implementational research. Now, this opportunity was developed in collaboration, technical collaboration with the WHO EMRO and the US CDC, and through a generous fund from the from TEFINET, the task force, we were able to really expand the number of awards that we were able to give and the number of projects that we were able to support. And the main goal was to address the burden, or I would say the growing burden of NCDs within the EMR by simply supporting and funding research projects that target prioritized and critical gaps in NCD prevention and management within their own countries. Next. So this initiative was launched on World Field Epidemiology Day in 2023, so September 7. Next. And we received so many proposals. We received around 30 proposals after the launch. And all of these proposals were reviewed by the technical committee that was composed of MFNET, CDC, and WHO EMRO. And these proposals really received very rigorous reviews until we selected 8 proposals to be, or 8 projects to be funded. Next. We announced the awardees last year in February, so exactly 1 year ago, and most of the projects started implementation beginning of March, and most of them were able to complete their projects between August and October of last year. And next. These 8 projects were from 5 countries, Afghanistan, Bangladesh, Jordan, Iraq, and Somalia. And today we will be able to hear from most of the participants. Unfortunately, the awardee or our colleague from Jordan could not make it to the symposium. However, we'll be hearing from all of the other projects. Next. Now, I want to take this opportunity to really highlight a key driving force behind the NCD Mini Grant Initiative, which is the Eastern Mediterranean NCD Research and Prevention Center, or what we call the NCDRC. This center was officially launched by AMFNet in 2023, and it really serves as a hub for NCD research capacity building and policy development. Next. Now, this center aims to enhance the prevention and the control of NCDs within the EMR and even beyond by simply fostering collaboration among various sectors and disciplines. And the team behind the NCD Research Center possesses a wide range of skills and expertise in designing and conducting not only epidemiologic, but also implementation research when it comes to NCDs. Because really, we want to see projects that actually advance the care and management and advance how NCDs are being addressed in the region. The overarching objective of this hub or center is to connect regional NCD priorities with evidence-based interventions, programs, and policies that can really effectively address NCD burden. So this center really operates under a framework of action, which we have published in our operational guide. And this was also launched 2 years ago, in January 2023. And I advise everyone to have a look at it just to know more about the work that we do when it comes to NCDs. Next. And I would also like to take this opportunity to reshare a resource that was developed by the center, which is the NCD Implementation Research Toolkit. Now we developed this toolkit to serve as a how-to guide, how to really implement an implementation and research project. It takes you from introducing the concept of implementation research is, what it really is, all the way to really developing a project design, implementing your project, collecting your data, analyzing it, understanding the contextual factors behind implementing any project, all the way to really monitoring and evaluating the impact of your project, focusing on certain implementation outcomes and indicators. And this resource is freely available. We also developed an online training that caters to this resource, also freely available. And I encourage everyone to really log on to AMFNet's learning management system, register. Registration is for free, and take this course at your own pace if you are really interested in implementation research and in specifically when it comes to non-communicable diseases. And with this, next, Ammar, I end my presentation, and I really want to say that as we move forward, we're really committed to supporting scientific research, scientific writing efforts, and expanding really the work that is being done from the region. And we encourage all public health professionals, whether you're an FETP, resident, graduate, a researcher, a policymaker, to really engage with us, leverage our resources, and collaborate with us to strengthen public health research and accordingly public health practice. I will not take more of your time. I know everyone's really interested in listening to our participants and the project. So I thank you very much for bearing with me, and back to you, Ruba.
Thank you so much, Dr. Randa, for this presentation and for showing case of different research initiative. So we look forward to having more events and activities that enhance scientific writing capacity, highlighting essential areas such as NCDs, and provide evidence about the impact of public health workers on the ground. So now let us begin with our first round of presentations. And this session will be facilitated by AMFNet's Technical Advisor for Sudan, Dr. Al-Fatih Malik, So please, Dr. Al-Fatih, if you can introduce each speaker and then manage the Q&A session. So please, Dr. Al-Fatih.
Okay, thank you very much, Ruba. I may face some issues of internet connectivity, so please be prepared to take over if any. So I'm glad to facilitate this session. We have 3 speakers. We are going to start with Dr. Ahmed Izzeddin from Sudan. So Dr. Ahmed, you have 10 minutes to present your case. Ahmed Izzeddin is an FETP graduate from Sudan. Ahmed, floor for you, and you have 10 minutes. I think the time is very, very tight.
Thank you, Dr. Fatih. I hope I'm clearly audible to you.
Yes.
Thank you. So I'm going to share my screen. Please let me know if the screen is clear. Can you see the screen?
Yes, we can, but please put it on presenting mode.
Yes, now it's in the presentation mode. Is it clear? Oh, sorry.
Yes, please go ahead.
Oh, just 1 minute. Okay. So is it clear now, Ruba? Sorry.
Yes, it's clear.
Thank you very much. First, I would like to show my honor to be part of this very important event. So good morning, good afternoon, esteemed guests, colleagues, and distinguished speakers. I'm Dr. Ahmed Izzeddin from Sudan. I'm a field epidemiology training program graduate working at the Federal Ministry of Health in Sudan. So my presentation will be on the multi-state cholera outbreak in Sudan and its ongoing armed conflict, 2023 to 2024. So as it's well known, cholera is a public health risk that is strongly linked to conflict settings, as conflict and humanitarian emergency settings provide suitable environment for the emergence and spread of infectious diseases. This is mainly due to the disrupted infrastructure causing disrupted health system with decreased and sometimes even lack of funding to finance preparedness and response, to the decrease lead to the decreased water quality, inadequate sanitation, and overcrowded shelters. These are all factors that facilitate the emergence of the infectious diseases. Sudan has a history of recurrent cholera outbreaks with high case fatality ratio, last of which was extended from 2016 to 2017, mainly at the southern parts of the country with significant morbidity and mortality. So in 2023, Sudan experienced a major outbreak of cholera affecting 10 states amid the armed conflict, the conflict that severely disrupted the health services. So this study was aiming to describe the magnitude and pattern of the cholera outbreak in Sudan amid the armed conflict from August 2023 to February 2024. And also to provide timely insights on the epidemiological situation in Sudan to direct national and international actors to mobilize more resources for preparedness and response. So the methodology, this was a retrospective record-based descriptive cross-sectional study that used surveillance data available at the national level, covering the period from August 2023 to February 2024, as I mentioned. So the attack rates were calculated using the available population estimates total age and gender disaggregated of in the affected states. You might know that the population has been changing since the eruption of the conflict, as multiple displacement waves have occurred due to the escalations of the conflicts in the different states. So we consider this changing population when calculating our attack rates. Crude and state-specific and gender-specific also case fatality ratios were calculated, and test for the differences. Difference between proportion was used to test the differences in attack rates across age groups and genders. For the data analysis, we used the EP-Info 7 software, and we use also the ArcGIS software to create the map to demonstrate the geographical distribution of cases in the different states. So the results of our study, according to the National Disease Surveillance, 9,581 confirmed cases reported from 10 states. This is in the period we mentioned. The duration of the outbreak varied across states, ranging from 4 weeks to 18 weeks, with an overall period of 24 weeks. So the overall attack rate for cholera was 3.5 cases per 10,000 population at risk, with the confidence interval shown. We have 4 states experienced the highest attack rates. These were the Red Sea state, Gaddafi state, Jazeera, and White Nile state. And these were the states hosted the greatest proportions of the IDPs, and those had a strained health system, and those states experienced heavy rainy season on top of the conflict. This is why they had the highest attack rates. Regarding the mortality from cholera, the cholera outbreak resulted in 338 deaths, with a crude case fatality ratio of 2.48%. And this is significantly exceeding what is recommended by the WHO, as the case fatality should not exceed 1%. And it is significantly higher than what is recommended by the WHO. So the CFR varied across the states, ranging from 1.3 to 4.6, with the highest case fatality ratios in Khartoum, Sinnar, and River Nile, as shown in. So the epidemic curve shown in this slide demonstrating the epidemic curve of the cholera all over the country. So it is very clear that the outbreak extended for a long period of time, 24 weeks overall, with the peak in the 49, week 49 in the year 2023, with the cases reported cases reach almost 1.5 thousand cases reported in 1 week. And then the outbreak started to decrease until it ends in week 8 in year 2024. The map is showing the geographical distribution of cases. This is based on deaths, based on the attack rate and the case fatality rate, which it's very clear that the Red Sea state here had the highest attack rate, followed by Gaddafi, and then Jazeera, and then Northern State, with the highest case fatality rate also shown in Kassala, Northern State, and Red Sea. So these are the recommendations from our study to better addressing cholera, and it is very well observed that it is a major risk in Sudan, especially during the current ongoing emergency. So to addressing this challenge imposed by the conflict, health authorities need to invest in local communities through strengthening engagement, raising awareness, and adopting community-based preparedness and response strategies, together with the readiness of the primary healthcare level through training of healthcare workers and maintenance of the flow of supplies. These are critical to reducing the significant mortality due to cholera. And at last, adopting a strategic outbreak preparedness and response financing mechanism by health authorities remain a priority, with the partner support being essential in conflict settings, as this will be a burden on the local health authorities to cover all the resources needed for the preparedness and response. So they indeed need support from other partners. So, and I'm very delighted to announce that we have our article published and is now available online at the International Journal of Infectious Diseases. You can find through the link. And I actually want to extend our deepest gratitude to the colleagues and mentors at the INFINITE team for their unwavering support and guidance during the scientific writing workshop, and even through personal communication. Thank you so much. You are all invited to visit the journal and go through our article for more details on the study. Thank you very much, and over to you, Ruben.
Thank you very much, Dr. Ahmed. You saved 1 minute from your time for us. Thank you very much. I'm glad to see this presentation. And I think let us go straight forward. We are going to open the floor for discussion after completing the 3 presentations. So let us go to our second presenter, Navita from Pakistan, is going to talk about scabies outbreak investigation in flood-affected village district in Pakistan. That is in December 2022. This is what is good about it. It is a mass case control study. So Navita, floor for you.
Thank you so much, sir. Is my screen visible?
Yes.
Yes.
Yes. Okay, can I start now?
Yes, you can start. You have 10
Yes.
minutes, Navita.
Yes, thank you so much, sir. Hello, good afternoon and assalamu alaikum, everyone. Myself, Dr. Navita Pardeep, FETP resident from Pakistan. And I want to thank you, NCD, and all my mentors from the NCD who guided me and give me this opportunity to present at this platform. Today, my topic of presentation is the outbreak investigation of scabies, which is conducted in December 2022 in a rain and flood affected village of Sindh, Pakistan. As we all know that scabies is a neglected tropical disease and it remains a significant public health concern. It is particularly in the low resource setting. It's highly contagious disease which is transmitted by the Sarcoptes scabies mite and is transmitted from human to human either by direct skin contact or through the contamination of fomites like through bedding or through the clothing. Scabies also affect globally and it has a prevalence between 0.3 to 46%, and every year about 400 million cases are reported. Pakistan is also affected by scabies and it has a prevalence ranging from 15 to 38%. Most outbreaks are reported in the areas where there is displaced population or overcrowded population and underserved communities, including Sindh province of Pakistan. Sindh has 30 districts, and on 26 December 2022, from one district named Sangar, it was reported to Provincial Disease Surveillance and Response Unit about increased number of skin disease that was diagnosed to be the scabies from a flood-affected village, Nasim Arain. And after the verification, The immediate response was initiated on very next day, that is 27 December 2022. A team was deployed, including FETP fellows, to the affected village, and we conducted a thorough outbreak investigation. The investigation was conducted to determine the extent of the outbreak, to determine the associated risk factors of the disease, and to recommend preventive and control measures. Here we can see the map of Pakistan. In the Sindh province, we can see here the district Sangar. I'm unable to show the highlighter. Okay, here's a district Sangar in which the Talka Sinjoro, out of 6 Talka, where the village Nasim Arai is located. It has a total population of 695 residents, and they faces very significant socio-economic challenges because the people, they struggle with the poverty, they have limited access to clean water, and their hygiene conditions were very poor. The village was severely affected by current rain and floods. Therefore, their living condition, their hygiene, and overall public health was very much deteriorated. A single basic health unit was available at a distance of about 3.5 kilometer distance, but this was difficult to access due to damaged infrastructures. In response to outbreak, we conducted a detailed epidemiological investigation in which the descriptive study followed by case control study was conducted, including 82 cases and 166 controls. Investigation was conducted between the period of 27 December 2022 till 31st January 23. All cases, they were identified using the standard case definition, and they were identified through the active search in the community and passively reported from healthcare facility. We defined a case that any person resident of village Nasim Arai, which have the skin manifestation of superficial burrows, intense itching, or generalized skin lesion or rashes with or without secondary infection between 15th August 2022 till 31st January 2023. For each case, we selected 2 controls, and any control that was the resident of village without sign and symptoms of scabies was enrolled. They were selected randomly from the neighborhood. In the data analysis, we included descriptive statistics with the time, place, and person. Attack rates were calculated, and adjusted odd ratios with 95% confidence interval were included. The p-value less than 0.05, they were considered to be significantly static. Yeah, we can say that they were significantly associated with the potential risk factors. It was included. Okay. In the outbreak investigation, we identified total 82 cases in which we searched actively 52 cases. However, 30 cases were reported passively from the healthcare facilities. The median age of individual cases was 17.5 years with the range from 8 months to 62 years. Overall attack rate was 12 cases per 100, and we can see that female gender was slightly high affected than the male gender, with the female to male ratio of 1.2:1, with the attack rate of 13 per 100. Most affected age group was 40 to 49 years with the attack rate of 17 per 100. Most common clinical feature identified was itching, which was present in 94% of the cases, and only 11% of cases they showed the presence of secondary infection. Here we can see that age group 40 to 49 have the highest attack rate of 17 cases per 100. And the female gender that is highly affected with the attack rate of 13 cases per 100. Here's the apical, and we can see there are multiple peaks, and it indicates that there is a propagated type of disease transmission from human to human over time. Here we can see the index case. The index case which started symptoms on 26th of September 2022. And upon investigation, it was found that index case has a history of travel to scabies endemic area. So it can be suggested that the outbreak, it can be triggered by imported case. We observed the last case reported on 12th of January 2023, and it marks the end of outbreak period. To control the outbreak, the action taken was the arrangement of medical camps. We also arranged health education and awareness session for the community for the early diagnosis and the treatment, and for the awareness regarding the personal hygiene, how to prevent from the disease transmission, and what are the importance of early treatment. Most common feature and sign and symptom that was observed was itching, that accounted for 94%, and followed by skin lesion, which was present about 74%. And the most common site of the skin lesion was found to be the interdigital spaces, followed by flexor surfaces of hands. Okay, we analyze 16 variables to assess the association between the potential risk factors and the disease occurrence. And these variables were selected on the basis of epidemiological relevance and what was their potential role in causation of the disease transmission. On the bivariate analysis, we found about 9 variables or the risk factors that seem to be positively associated with the disease occurrence and the transmission. However, after the logistic regression, we found that the cases who have the positive history of contact with the disease positive person and who have history of sharing their beds and the personal items like clothes and the towels, they found to have the causative association with the disease. And the persons who were frequently taking bath and frequently changing clothes and whose family member size was less than 6 in a household, it found to be the protective factors against the disease transmission. The outbreak occurred in a flood-affected village where there was lack of clean water and there was limited access to medical care. And it was noted that the index case has a travel history to the disease endemic area. So most likely the outbreak was triggered by the imported case. Because there was shortage of water, so the bathing and the washing clothes frequency was also reduced, and it provided a favorable environment for the mite to survive and cause increased transmission of disease. And here we can see that the overcrowding and like the families who have the family members more than 6 and living together, they have increased chances of disease transmission. And those who were sharing their personal items, they were also at increased risk of disease transmission. There are combination of health education and awareness sessions which were conducted in community regarding personal hygiene, how to prevent from the disease transmission, and the capacity building of the healthcare providers for the early detection and the diagnosis of the disease, and also provision of the clean water, which should be sustainable. These contributed in containing the outbreak and reduces the future risk of disease outbreak. So there should be continued community engagement and establishment of infrastructures for the maintaining the disease prevention efforts in the future. Here are some pictures from the field. And thank you.
Thank you very much, Navita, for bringing this topic up. I think scabies is a major public health problem in our region, and I would like to see more researches in this area. So thank you very much for touching on this issue, and I think you have presented your case very nicely. So let us and use your time as specified. So let us go to the third presenter. Fatima from Yemen is going to present about adherence to treatment regimens among end-stage renal disease patients. Fatima, the floor for you.
Yeah, I'm here. The voice is clear? I'm here. The voice is clear?
Yes, yes.
Yes.
I will share the screen now. Is the screen is visible?
Screen is not visible yet, but the voice is clear. Your voice is clear. So we are waiting for your screen.
Now it's coming.
I think just this is a very important session, I think, and it seems that it's important come from, there are more than 300 participants now.
Yeah.
Yeah. So Fatima.
So I think it's clear now.
Yes, it is clear. So you have 10 minutes.
So, Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim.
Marhaba alaikum salam.
Thank you for the invitation. End-stage renal disease can lead to unavoidable consequences. So, for enhancing the treatment outcome, comprehensive management adherence is vital. The title of this project is Treatment Adherence and Perception. Treatment adherence and perception to hemodialysis regimens among hemodialysis patients at a Thora Modern General Hospital.
Dr. Fatma, can you please just put it on presenting mode?
Yeah.
Thank you.
Now it's clear.
Not
Hello?
yet. Not yet. I think it takes some time.
Maybe because the internet connection is bad somehow.
Don't worry, it is good. So I think she can continue and then waiting
Yes,
for.
yes.
Yeah.
It's clear now.
Continue. Yeah. Continue, Fatima.
4 domains should be concerned in the treatment of hemodialysis patient. The first one, adherence to hemodialysis session. The second one, taking appropriate medication, fluid restriction, and dietary modification. As well as general perception can play a major role in patient adherence to their treatment. Here are some statistics. In a study conducted in Palestine, non-adherence to hemodialysis treatment was reported in 48% of participants, while non-adherence to diet modification was reported in 76% of participants. This study aimed to determine the level of patients' adherence to hemodialysis treatment domains, assess the perception and counseling of patients, determine the association between patients' socio-demographic characteristic and clinical factors, perception and counseling toward the adherence on hemodialysis treatment domain. It was a facility-based cross-sectional study conducted on Urology and Nephrology Center at the Thora Hospital, which hosted 480 hemodialysis patients. This study included patients who received hemodialysis treatment for at least 6 months, and they received hemodialysis session at least 2 times weekly, also accepted to participate in this study. Data collected through interviewing patient face-to-face using end-stage renal disease questionnaire. The primary, or for the study variables, the primary outcome is adherence to treatment or adherence to 4 domains of treatment regimens. Also, the secondary outcome, perception of patient toward the importance of following the 4 treatment domains, as well as counseling. Independent variables included socio-demographic, clinical variables, perception, and counseling. For measurements, scoring subscale used to assess adherence for each domain and overall behavior. The level of adherence characterized as poor, moderate, and good. Perception question ranged from 5 to 1. For counseling question, negative answer collectively counted. Data entry and management using EBINFO and the ethics and consent was approved. For the result, this table demonstrated socio-demographic characteristic of hemodialysis patient. Out of 480 patients, around 393 patients accepted to participate on the study. The mean age for participants was 45 years. The majority of participants were male, living in urban places, married, educated, and about 92 of participants percentage of participants were unemployed or retired. And the overall gain score for the 4 domains was 932.5, which indicate the moderate level of adherence, and almost half of patients reported good level of adherence. There is some technical problem here because the screen is not moved, or the slides not moved.
Dr. Fatma, if you have problem with the internet connection, you can stop sharing and we will share the screen from our side.
Please share the screen from your side. Thank you.
Please, Ammar, if you can open the 3rd presentation.
And this slide. Thank you. Regarding the medical history of patients, about 80% of patients were hypertensive, and about 62% of patients undergoing hemodialysis sessions for less than 5 years, and about 9% of patients had kidney transplantation, and only 2% of patients received peritoneal dialysis. Next. Here, the overall adherence gained score, as we said, it reached for 77%, while the good adherence represented in 48% of patients. Next. Regarding hemodialysis session, the patient reported a good for attendance hemodialysis session and moderate for medication, fluid, and diet. Next. The majority of participants had a good perception toward the importance of following dialysis session, medication schedule, fluid, and dietary modification. Next. The percent of patients who non-received counseling regarding hemodialysis was 82% for medication, 65% For fluid and diet, 69%. Next. Here, this table clarified the significant socio-demographic and clinical characteristic associated with reported adherence behavior. We show here there is a significantly association with patient with a higher main scores among patient with shorter duration of hemodialysis and living in urban places. Next. Also regarding perception, here we observed that higher main scores showed with among patient with perception to medication, perception to fluid restriction, and perception to diet. Next. For counseling, there is a significant association between adherence behavior with lower mean scores of counseling to fluid restriction and counseling to diet. Next. To conclude, adherence to hemodialysis therapy among study participants was moderate, significantly higher mean scores among patients with hemodialysis duration less than 5 years, urban residency, patient with a perception of medication, fluid and diet recommendation, significantly lower mean scores among patients who had not received counseling regarding the importance of dietary modification and fluid restriction. Next. For recommendation, regular counseling should be provided to improve adherence level, especially regarding dietary and fluid recommendation, delivering counseling and medication to hemodialysis patients from rural areas for enhancing their commitment to various treatment items, conducting a multi-center study to assess causal relationship between adherence and affecting factors. Next. Thank you for your listening.
Thank you very much, Fatima from Yemen. She presented adherence treatment regimens among end-stage renal diseases. So now we have the three presentations completed. We have Ahmed Izzuddin from Sudan. He presented about outbreak of cholera. And we have Dr. Nabita from Pakistan. She presented her case control study about scabies outbreak investigation in Pakistan. And we have Fatima presented adherence to treatment regimens among end-stage renal disease patients in Yemen. So now the floor is open for comments and questions. I'm going to give you the chance, try to make your question or comments directly straightforward so that more people can share their comment and questions. So please help me to identify who is raising his hand.
Dr. Al-Fatih, I think the floor is not open for direct participation. However, there are a couple of questions written in the Q&A section.
Yeah. So
yes,
please go ahead.
Okay, so we have a question regarding the cholera. So the question is saying that in cholera is more important, the public awareness is more important in cholera, source of a clean drinking water. However, in the recommendation, it's not stated like clearly. So do you have any comment on this, Dr. Ahmed?
Yes, thank you, Dr. Ruba. For this point, actually, because of the time limitation, we didn't go through everything. So, but we include this under the preparedness. So we need to invest on the preparedness, and this includes the water infrastructure and and working on the source of clean drinking water and so on. So, but for the awareness, we clearly stated this as part of the community engagement and raising the community awareness so we have better outcomes if any outbreak happens in the future. So I think there is another point, so I can go through the other point. for the time sake. The next question is cholera is waterborne disease, so need hypothesis that way and how this happened. So yes, actually a more better study will be that go deep to answer the question why cholera occurs and what are the source of infection and what are the potential spread factors and so on. So our study was a cross-sectional descriptive study that was record-based. So we were not able to answer such question on the hypothesis of why and how the outbreak happens, but we are working now on a more in-depth study to answer such questions, like an analytical study, which is test control
It's
study.
clear.
Thank you.
Yeah.
Thank you.
Point.
Thank you.
So what next, Ruba?
Thank you. All right, so we have a question from one of the audience that says, I strongly believe certain groups of population are neglected in public health research and initiatives, and little to none attention is given to specific groups, especially adults aged above the age of 65 are considered as neglected public health groups. Even though advocacy plays a great role, how could research and researchers impact the attention given to this specific group? So I think this is a general question, so I'm not sure who can take this and comment on the what mentioned.
I think it may be good to keep this question to the end of the whole presentation, and then you can raise these questions because it is not related to this session.
Yeah, okay. So we have a question, how we can eradicate scabies. It causes psychosocial problems in infected individual and community. So Dr. Navita.
Yeah. We can eradicate scabies by preventing its occurrence. Like if we improve our personal hygiene, we improve our routine, like taking daily bath, and prevent the contact from the positive person, we can prevent the infection. Yes, it's true because it causes the psychosocial problems, because once we get the infection, so it's a long-term treatment, and the treatment, it is also, you can say it's a costly treatment and it's a long-term treatment. It can cause the psychosocial problems. So the one way we can eradicate, I cannot say we can eradicate, but we can prevent from the scabies by keeping our personal hygiene improved and preventing, increasing awareness and awareness of the community regarding the disease transmission.
I think the key, this is just from my opinion, the key is raising awareness, because it is even common among high socioeconomic group. So I think high socioeconomic group is going to work, but again, awareness is the most important.
Thank you,
So,
thank you,
Ruba?
Dr. Al-Fatih. Thank you, Dr. Navita. I think we have no questions left for these presentations. So maybe we can move to the next presentations. Dr. Al-Fatih, do you have any final thoughts before moving ahead?
I think just to, I would like to congratulate the Infinite for this efforts. And I think the three presenters have presented good. They are talking about major public health problem, and it is well presented. Thank you very much.
Thank you so much, Dr. Fatih.
Ruba, also, if you allow me, sorry for interrupting. This is Renda. A lot of participants are writing their questions in the chat. I just want to remind them, if you have a question or a comment to one of the presenters, please write it in the Q&A section so that we can follow it. It's very difficult to follow the conversation on the chat. Also, if you have a specific question that was not answered to one of the participants, I encourage you to actually type within the chat your question and dedicate it to that specific participant or speaker, so that they can answer you privately or connect with you privately and share more information on their study. Thank you, and sorry for interrupting.
Thank you so much, Dr. Randa. And for the sake of time, if we did not answer all the questions, we'll make sure to get back to you with an answer after this session as well. So now I'd like to invite Dr. Huda Hakim, Technical Specialist at MFNet, to introduce our next speakers and facilitate the question and answer session. So please, Dr. Huda.
Assalamu alaikum. I'm Dr. Huda Hakim, as Ruba said, technical specialist at the International Academy of Public Health. I am very happy to facilitate this session, which consists of two presentations from Sultanate of Oman and the second one from Egypt. We will start by the first one, which will be presented by two presenters, Dr. Sabriya Al-Marshudi and Dr. Fatma Al-Hashimi. The research or the presentation is about the first cluster of monkeypox in Oman during October 2023 outbreak investigation study. So the presenter can start. You have 10 minutes to present your work.
Good morning, good afternoon. Can you hear me?
Yes.
I will share my screen. It is clear. Is it clear?
Yes.
Yes.
Yes. So, good morning, good afternoon, everyone. My name is Dr. Sabriya. I am head of vector-borne disease and emerging disease in Ministry of Health, Sultanate of Oman. Me and my colleague, Dr. Fatma Al-Hashimi, will introduce today an emergency of Mpox in Oman. Investigation, the first cluster and its implication in October 2023. First of all, we would like to thank you, MFNet, and to thank all the doctors who give us the presentation and the lecture and the guidance, and we are highly appreciate, and we hope you enjoy our session. So Oman is located in the Middle East of the southeastern and end of the Arabian Peninsula. The capital of Oman is Muscat, and Oman is bordered by three countries: Saudi Arabia, United Arab Emirates, and Yemen. So CDC of Oman is under Ministry of Health, and it's responsible for leading the national public health response and the timely prevention, detection, and response of all public health hazards. In Oman, we have a communicable disease guideline which illustrates all the priority disease for reporting and management. These priorities are categorized of disease to three types: Group A, which is supposed to notify within 24 hours, and monkeypox or Mpox is one of those diseases. And this categories is according to the risk assessment and international public health practice. Additionally, we have an incident command chains for reporting all the cases to ensure early notification from all health institutes. Moreover, the notification is done through electronic surveillance system, which is established by Ministry of Health to report all suspected and confirmed cases. Also, we have a rapid response team at national and governorate level, which is their aim is the primary role is to ensure coordination, surveillance, prevention, and response effort. And it's contain a multi-sector from different professional, and all the role and responsibility has been illustrated. So if we come to our topic, Mpox is caused by a zoonotic orthopox virus, and it has two clade 1 and clade 2, which is and clade 2 which is caused in the 2022 and the 23 outbreak. The transmission is occurred through direct contact with the skin lesion, respiratory droplet, and contaminated surface. The symptoms include fever, fatigue, lymphadenopathy, and in addition to that, the characteristic rash lasting 2 to 4 weeks. The diagnosis is done by taking a sample from the skin lesion for PCR, and the management is early detection, isolation, and symptomatic treatment to prevent further spread. So our aim is to describe the case, identify the source of infection, prevent the transmission to the healthcare worker and the community. In addition, the sensitivity of the suspected monkeypox cases among healthcare workers. So in Oman and the CDC, as soon as we heard about any alert or any diseases, so we start formulate our review, our guideline to distribute to the all countries. First, so as soon as we notice that globally there is an outbreak about mpox, we start formulate our guideline. In addition to that, the case definition is illustrated. Our paper is about outbreak investigation studies, and it's involved all 3 confirmed cases of mpox using the previous reported form of epidemiological investigation of the case and another form for detailed contact tracing. So as soon as the suspected case from a notification system is alert to the national level and the governorate level, we start our homework and the PCR become positive. So this case is confirmed as positive case. So what's the measures that we did? The Ministry of Health start redistribute their guideline again to those governorate. Rapid response team immediately activated. Alert and case definition circulated to all private and government health institution. In addition to that, field investigation to the house, work, and all health institution where the patient visits since the onset of the symptom was conducted. Relevant material and information regarding the mpox disease distributed to the healthcare workers and to the community. In addition to that, all contact were tracing and follow up on their symptom for 21 days from the last contact within the patient. So now my colleague, this is the flow graph which is described the monkeypox and the suspected case, and when we report the probable case and when we said it is confirmed case. Now my colleague Dr. Fatma will continue.
Thank you, Dr. Sabriya. Good evening, good morning. So I'm Dr. Fatma, as Dr. Sabriya mentioned. I'm a Director of Disease Surveillance and Control in North Batna Governorate under Ministry of Health. So I will continue with the result. The result revealed that there were 3 confirmed cases of mpox within a single family. All cases were Omani in nationality. 2 cases were adult, 2 cases were male, and all patients were fully recovered. The index case was 43 years old, Omani male, married, developed a typical mpox symptoms such as fever, generalized body ache, lymphadenopathy, and widespread of erythematous, papular, pustular skin lesion. The patient gave a history of travel to a neighboring country and he stayed for a few hours according to the patient. The patient denied any history of sexual contact, neither contact with a suspected case or any case with a similar rash. And there was no history of contact with animals. The diagnosis of the index case was delayed for 7 days after the onset of the symptoms, and the patient was diagnosed at earlier time as a chickenpox because there was no cases of mpox in Oman previously. The second case was the index wife case, and she was 34 years old. The third case was his son. He was 10 years old. For the second and third case, they showed atypical rash in type and in distribution. All cases develop fever and lymphadenopathy, and 66.6 develop sore throat. The index case only developed a typical monkey mpox rash. All cases were diagnosed by a real-time PCR. The viral sequencing for the index case showed MPV clade 2B, which was circulating worldwide during the outbreak of mpox in 2023. So the possible source of the infection for the index case was travel-related. Transmission to secondary cases, the second and third case was through close contact with an infected person via body fluid, lesion, and respiratory droplet. Next, Dr. Sabriya. So in order to minimize the transmission to the healthcare worker, the index case was isolated with strict infection control measures and only a limited staff attended to the patient. And all healthcare workers who were in contact with the patient were monitored for 21 days after exposure. The contact of for the patient, whether the index and the secondary cases, were divided in high risk contact, mainly household contact, and low risk contact, the co-worker of the patient and healthcare worker who are in contact with the patient. All contact were followed for 21 days from the last exposure to the cases. Alhamdulillah, there were no secondary cases outside the household. For example, no cases in the school, community, and workplaces. Institutional isolation for the cases and contact was offered to prevent the spread of the infection outside the family and also to avoid stigmatization to the family. Next, Dr. Sabriya. So the discussion, this is the first cluster of Mpox outbreak in Oman. Close household gathering likely to trigger the spread of the infection. This outbreak highlights several key learning points for the timely detection, prevention, and control of Mpox. In this case, there was a delay in the recognition of the symptoms and isolation of the index case, and this led to exposure to multiple high-risk contacts, contributing to the spread of the disease. Prompt identification and immediate isolation of the suspected cases are critical in reducing secondary transmission, particularly within household and healthcare settings. Moreover, the implementation of institutional quarantine for contact, especially children, proved effective in preventing the spread to a wider community, as demonstrated by a lack of further cases in school and workplace. Next, Dr. Sabriya. So another important aspect of this outbreak was balancing the need for effective disease control with respect for patient privacy and dignity. In this study, family members were provided with clear guidance on isolation and hygiene practice, while efforts were made to maintain their privacy throughout the process. This approach is very vital and very important in maintaining public trust and ensuring that the individual feel comfortable seeking care without fear of stigma or discrimination. Additionally, history taking in disease like Mpox can be complicated by current social stigma, particularly within the men who have sex with men population. In this case, the index case denied any sexual contact, which may have been influenced by fear of judgment or stigmatization. Accurate and thorough history taking is very essential for understanding the true epidemiological context, but it requires creating safe and non-judgmental environment where individuals feel comfortable disclosing sensitive information. The calculated secondary rate in this outbreak was 33%, while it is high and it is higher than the rate reported in the other studies. Prompt isolation of the children in institutional quarantine before they could interact with the classmate helped prevent further community spread. Next, Dr. Sabriya. So the recommendations are public health responses should prioritize the timely detection, appropriate control measures, and respect for privacy, cultural sensitivity, and local capacity, including quarantine protocols for close contact. Investment on building capacity for regional and global molecular epidemiology network can further aid cross-countries outbreak investigation and source tracing. Thank you to all audience, and special thank to Infinite Mentors and the team to give us this opportunity to present our paper. Thank you.
Thank you.
Thank you, Dr. Sabriya and Dr. Fatma, for the nice presentation and the unique topic. For all, as Dana said, you can put or write your question on the Q&A icon. or you can, if you are using your mobile phone, you can write your question on the chat, and then it will be transferred or shift to the question and answer icon. Okay, now we will go to the next presentation from Egypt, which is investigating the respiratory viral patterns, RSV, influenza, and COVID-19 in acute respiratory infection surveillance in Egypt 2023 and 2024 by Dua Mustafa.
Hello, doctor. Is my voice clear?
Yes.
Excuses that I will share from device and speaking from another device due to a technicality issue.
Okay.
Okay, is the screen is
Yes, it's clear. Yes, you can start now. You have 10 minutes, Dua.
Okay. Good afternoon, everyone. I'm Dua Aladdin from FETP Egypt. It's my pleasure to be here today and share my research. In the past century alone, we faced many viral pandemic, especially respiratory one from Spanish flu to COVID-19. That's why we are continuously interested in studying the changing pattern in the respiratory virus. Our topic today, investigating respiratory viral pattern, RSV, influenza, and COVID-19 in acute respiratory infection surveillance Egypt, 2023-2024. Acute respiratory infection is a significant cause of morbidity and mortality on a global scale. Among children under 5 years, the area contribute to 11 to 22% of fatality, especially in developing countries, while in adults aged from 15 to 49 years, it represents 3% of fatality. In Egypt, ARI is monitored through a routine and central site surveillance that monitor activity of influenza, RSV, and SARS-CoV-2 across 16 central sites located in 13 governorates. ARI in Egypt represents nearly 18 of all reported communicable disease and accounted for 9% of hospitalized patients in central sites. The situation in Egypt, while COVID-19 pandemic, there was a decline in influenza and RSV cases. Post-pandemic, there was a surge in RSV and influenza, and this appeared in many parts in the world. And we are seeing now the current situation in 2023. Our objective was to describe the epidemiological and the clinical characteristics identified as circulating virus in every cases. The method, it was a retrospective analysis for the data extracted from the reported cases from NCD-Focused. NCD-Focused is the National Egyptian Electronic Disease Surveillance System occurring in central sites in Egypt. The case definition was updated in this area from SARI case definition to extended SARI case definition, especially for the RSV cases. The inclusion criteria included the first 20 patients weekly, regardless their age. The data is collected on a standardized tool collecting data about demographic, geographic, clinical characterization, and the
Sorry, Dr. Dua, we cannot hear you.
Okay, from the lab procedure. The lab procedure was oropharyngeal and nasopharyngeal swab and tested for the respiratory virus by real-time PCR. The data analysis was done using SPSS and GraphAPAT, and quantitative data represented as proportion, quantitative data represented as interquartile range. Statistical test used was confidence interval chi-square and Kruskal-Pascal test. Result throughout the period of January 2023 to February 2024, 12,000 cases, 354 cases were enrolled as suspected early. From those, 10,179 patients was tested concurrently for the three virus. From this total tested, we have influenza has 11%. 70% as flu A and 3% as flu B, and RCV accounted for 9% of cases, and COVID accounted for 3% of cases. Looking at the epidemic curve for the three virus, we can see a concurrent seasonality between the influenza virus represented in blue and RCV virus represented in red, with the influenza season starting 10 weeks earlier than the RCV. And the COVID-19 has two small waves. It was synchronized with the international wave in that time. When comparing the demographic pattern in regard the age group, we can see that in the influenza, the age group was nearly equal distributed between all age group, while the RCV was highly shifted toward the age group under 2 years, and COVID was more shifted to extreme age group between age under 2 years and age older than 50 years and 65 years. When comparing the symptom according to patient, the RCV was the lowest associated with fever, while COVID-19 was the highly associated with cough. Tachypnea and tachycardia was the highly associated with RCV, while pleurisy was highly associated with influenza. In the term of severity accounted for hospitalization days and ICU duration, we can see here the hospitalization day represented in blue. COVID it is represented as interquartile range. COVID-19 has the higher interquartile range between the three viruses, while the RCV has the longest ICU length of stay. With regard to comorbidity and the ICU admission rate, the COVID has the highest comorbidity and highest association with ICU admission. With regard to outcome and mortality, COVID has the highest complication with pneumonia and ventilation, and mortality rate 14%. In conclusion, COVID-19 exhibits severe outcome and high fatality and was highly associated with comorbidity and ICU admission rate. RCV has the longest ICU length of stay. ICV was lowest associated with the most common symptom like fever and cough. Recommendation, surveillance enhancement to include more pathogen to guard against a high percentage of negative patients, necessity for prioritization for vaccination for the high-risk group, adequate preparation for the overlap season, and necessity availability of hospital bed with isolation facilities with critical care resources, and we should implement robust public health measure in time of overlap season. Thank you. And I thank all the FETP team in Egypt and the Infinet team for this opportunity.
Thank you, Dua, for the good presentation. I think we have a number of questions, mainly for Dr. Fatma, Dr. Sabriya. The first question for Dr. Fatma, can you tell how many cases reported at Oman and the origin of cases?
Thank you for the question. During 2023, we have these three confirmed cases. Then in 2024, we have 2 confirmed cases. All cases were travel-related outside Oman. They came with the symptoms from outside Oman.
And there is another...
no secondary cases. No secondary cases except for first cluster because the diagnosis was delayed was delayed for almost 7 days. So there was like a secondary cases within the household family. But for the two cases in 2024, there were no secondary cases.
Okay, there is another question regarding the index case, the origin of the index case of monkeypox. It is important to know what are the distinguishing features from chickenpox so that a delayed diagnosis doesn't occur. But the question regarding the index case. Okay.
You mean the symptoms of the patient?
No, the origin.
No. The origin
From where?
of
Yes.
the cases is from actually in the worldwide is it's actually mpox was an old disease. So the original of the disease is from Central and West of Africa, where the mammals was most commonly at that area.
Yes, they are asking about the index case of Oman. You
Of
said
Oman.
he is coming from outside the country. He was traveling outside.
Yeah, he was traveling outside the country to neighboring country. He was traveling to UAE. And and he visit industrial area, and there was a lot of expatriate in that place. And he gave a history of contact, but the patient denied any sexual contact. And the viral sequencing for the virus, it showed the 2B, which was circulating in 2023, which was circulating and causing the outbreak during 2023. And this like give us a proof that the virus is imported from outside the country.
There is another question also for Dr. Fatma and Dr. Sabriya. Did you assess the immunity status of the candidates or of the patients of monkeypox?
Yes, for the index case, the patient was immunocompetent. He was, and we tested him also for other STI disease to know if he has like any other diseases such as HIV, syphilis, and the patient was negative. When his wife developed the symptoms, we are thinking maybe the wife is the index case. So also we test his wife for syphilis, for HIV, and she was negative. The thing to mention, his wife was DM, was diabetes mellitus patient, and hypertensive and hypothyroidism. But the index case was immunocompetent.
Okay, there is another question also. What is the external validity of the monkeypox intervention strategy and the genetic linkage for monkeypox? 2 questions.
Maybe this question is for virologist.
Maybe the genetic linkage for monkeypox.
Yeah, because the viral sequencing, as I mentioned, was clade 2B. Yeah, for the index.
Okay, thank you very much, Dr. Fatma and Dr. Sabriya. I think there is a question for Dr. Dua. The findings or the results of regarding the results of your research, it will affect the vaccination policy in Qatar, especially for RSV vaccination and influenza. How these findings will affect the vaccination policy in Qatar? For Dr. Dua.
I think it's in Egypt, but by mistake.
And influenza, in Egypt, yes. Yes.
In Egypt, how it will affect the vaccination policy in Egypt? I think with spotting the main age at risk from this virus, we can interested in giving the vaccine to this age as it's 88% in kids under 2 years. So if we thinking in introducing RCV vaccine, it will we will think in this age group primarily.
Okay, thank you, Dr. Dua, and thank you, everyone. I don't know, Ruba.
Thank you so much, Dr. Huda. So here I'd like to thank also all our presenters and facilitators for this informative session, and our participants as well for raising these insightful questions. So now we'll have a break, 15 minutes break. So we will come back at 4:50. Please stay connected and we'll meet you again at 4:50. Thank you.
Thank you very much.
All right, I think we are ready to come back. Okay. Welcome back. And now we will move to the second round of presentations in a session that will be facilitated by Dr. Zakir Hussain, Country Manager of the MFNET Pakistan office. Dr. Zakir, the floor is yours, please.
Yeah, thank you, Ruba. This session is about the NCD-Focused mini grant presentations. And we have three presenters and three presentations in this session. The first presentation is by Dr. Abidur Rahman Ibrahim from Somalia, using the consolidated framework for implementation research to identify and address barriers to the implementation of NCD programs in Somalia. So Dr. Abidur Rahman Ibrahim is present.
Yeah, hello, can you hear me?
Yeah, doctor, you have 10 minutes for presentation. So please go ahead.
Yes, let me share the screen. Can you see my screen?
Yeah, we can see your screen. Please start.
Yeah. Thank you so much. Good afternoon, everyone. It's my honor to present our research projects under the MVNet and TVNet mini grant initiatives. Today, I'm going to be sharing our work on addressing and identifying the barriers to the implementation of NCD programs in Somalia. Our study will not only highlight the critical challenge in NCD care that are tailored strategies for change in the region. And this is a brief biography of me. For the sake of time, I will skip. And this slide is an overview of what we're going to be presenting by starting pattern of NCD in Somalia, health service, especially NCD interventions integrated within the package. And then we will discuss about the research questions and the aims of our research, and then the implementation research framework that we adopted. And I will then detail the study design, and then I will present the key findings and the key takeaway message. Starting from the burden of NCD in Somalia, non-communicable diseases are emerging as a major public health challenge in the country. Chronic conditions like cardiovascular diseases, diabetes, and cancer are now accounting for 1% of all deaths in the country. And this shift is largely due to the rapid urbanization, lifestyle change, and the adoption of unhealthy behaviors that have been adopted because of the country is recovering from the conflict. However, a significant challenge is the limited epidemiological data that's available, especially for the NCD care. And that, needs planning and that limits planning and resource allocation for the NCD care more difficult. To address the multifaceted health needs of its population, Somalia has introduced the essential package of health interventions in impact in 2009 and later revised it in 2020. And the first version was not, and the NCD package was not included in the first in the first version. And later, after 2020, it was readapted and integrated the non-communicable disease package. And if you see, if you look into the package, you're gonna see the, you know, the different interventions together. It's almost like 170 interventions intended to implement across 5 service delivery levels, starting from the community centers, primary healthcare unit, health centers, district hospitals, regional and national referral hospitals. And the main problem, as Reynolds and Ital mentioned, is the essential package of health services only have impact when implemented. And many countries that there are still a large implementation gap. So critical translational work is needed to move from the criteria-driven formulations to package designed to support implementation. So in here, our study is driven by a central question, which is how we can identify and overcome the pre-implementation barriers in Somalia. To address this, we have set 2 primary aims, which is to systematically identify the pre-implementation barriers affecting the rollout of NCD integrated EBHS interventions using the consolidated framework for implementation research. And after we find out the barriers, we wanted to develop context-specific, evidence-based, recommended implementation strategies to address the identified barriers using the severe ERIC margin tool. These 2 of the research, the implementation framework that we are going to use is, you know, these 2 tools, which the first one is consolidated framework for implementation research. And the CPER framework usually provides a robust structure to analyze multiple dimensions of implementation, starting from the intervention characteristics, the inner and outer setting, as well as the individual and process factors. Complementing this, we have also used the expert recommendation for implementation change to, you know, these 2 frameworks will guided us, you know, by not only identifying the barriers, but also systematically mapping out tailored interventions, tailored solutions for effective NCD program implementation. Regarding in-depth interviews, you know, wanting to find out the implementation barriers. After we identify the barriers, then we match the ERIC margin tool to develop a recommended strategy. And the stakeholders involved in our study were the OVMOH, NCD unit, the state level representatives, the healthcare providers, especially the doctors and nurses, involved communities, people living with NCD and their families, public hospitals, international and local partners. And this was our implementation plan. We had 3 phases, starting from the planning phase, the implementation phase, and the execution phase. And the key events, starting from our desk review, used the health system building block framework. And then we analyzed and the NCD, for example, in the NCD governance and leadership parts, we have department with regular quarterly NCD technical working group meeting. But we also identified that there is a weak coordination and lack of NCD focal points at the state and regional health authorities. There was also a limited political commitment and prioritization of NCDs among all actors and accountability, since the country is still struggling with the maternal and child health conditions. And we also identified that there was no intersectoral collaboration with non-health ministries, especially in the education and the agriculture sector. And we also have identified that there is a heavy reliance on external donors, which risks the sustainability. And there was also a high out-of-pocket expenditure in the private sector. In the NCD service delivery, the NCD services that are provided in the public health facilities have been increased from 9% in 2016 to 50%. But the limit was only confined to urban and the suburb areas. There was a disparity in the rural, poor access, weak infrastructure, and referral systems. We also identified that the cancer care nearly absent at the primary levels, and there is a minimal services that are provided in the tertiary care services. Regarding the health workforce, there is a shortage of trained staff, especially in the rural areas. There was a limited capacity building programs and professional development. Regarding the financing and resources, there was a heavy reliance on donors. Government funding was insufficient. And there was usually frequent medication stockouts, especially in the public health hospitals. On NCD care, there was a low public awareness of NCDs, and especially negative religious beliefs, cultural and financial barriers, which limit the NCD care access. And usually the existing programs are fragmented. Stigma and around chronic disease is very prevalent. Regarding the health information system, and the country uses the district health information system 2, in short, DHIS2, and it's in its early stages. It's limited in terms of NCD data for action planning and decision making. There is a limited NCD indicators even in the DHIS2. Regarding the epidemiological burden of NCD in Somalia, NCD currently causes around
Dr.
24
Rahman,
to 30%.
you have already consumed 2 more minutes than your time, so please hurry up.
Okay. And this is the in-depth interview in our research. We identified using the CIFER framework that there was a difficult inadaptability of the intervention, the complexity, the cost of implementing the services, and outer setting, emergencies and outbreaks were the main hindrance of NCD care. Sociocultural was inadequate infrastructure, and there was a focus on acute care rather than NCD management. In the individual, there was a lack of training for mid-level managers, and in the implementation process, it was poorly structured in terms of the plan. And this is, like the intervention and outer setting domains in detail. Then we skip. And after we have identified the we set using the ERIC match strategies in order to develop specific strategies. So our context is specific strategies. We're mainly focused we identified. For example, regarding the cost, we have proposed that in order to develop, we need to partner with the Somali diaspora and the private sector to fund NCD care and performance-based establishments for health work critical conditions. We have proposed that there should be an inclusion of emergency response strategies in NCD implementation plans. For example, regarding the organizational culture, we have proposed we need to identify and partner with and train cultural champions to promote a shift towards prioritizing NCD care within the health system, embedding it into the organizational culture. And finally, my key takeaway message is, to consider localization and contextualization of NCD, and in order to fit the Somali culture, infrastructure, and the resource realities that are existing in the country. We also need to strengthen our health system, invest in the infrastructure, the workforce training, and supply chains. We need to also prioritize policy and leadership to develop national NCD policies and secure high-level political commitment. We need also to engage communities culturally. We need to secure to have a secured, sustainable funding, and we need to have also an adaptive implementation, plan in a small scale, and then we need to refine and scale up, allowing flexibility for conflict-affected areas. And finally, my key takeaway message will be to, in those multi-sectoral collaboration, across health, education, and agriculture sectors to address NCD factors. This was our research team to give thanks and appreciation the support from and cabinet. That's all. Thank you so much.
Thank you, Abdul Rahman. You are 5 minutes taken more than your allotted time. So I would also advise to all other presenters to please keep in mind that you have 10 minutes for your presentation. And when you are preparing the presentation before this symposium, you have to practice it and make sure that you finish within the time limit. That would be helpful for your future presentations also. So our next presenter is from Afghanistan, Dr. Marzia Muhammad. She's presenting the improving hypertension management in Afghanistan, a small-scale intervention using WhatsApp for hypertension education and follow-up. Dr. Marzia.
Okay, thank you. I will share my screen.
Yes, please.
Bismillahirrahmanirrahim. You can hear my sound?
Yes, we can hear you, and we can also see your presentation. Please go ahead.
Thank you. Hello and good evening, everyone. I'm Marzia Mohammad, graduate of Afghanistan Field Epidemiology Training Program. I'm very happy to share the result of this study on behalf of my colleagues who collaborated me on this regards. The result of this study and that I will share with you is on the other slide, and the title of the research is Improving Hypertension Management in Afghanistan, a small-scale intervention using WhatsApp for hypertension education and follow-up. I tried to change the slide, but it is a problem. Yeah. As you know, better cardiovascular diseases are accounted as leading cause of mortality worldwide, with a majority of cases related to hypertension. And in 2019, number of adults living with hypertension has doubled from 50 million in 1990 to 1.3 billion in 2019. In the Eastern Mediterranean region, the estimated prevalence of hypertension is 38%. Also in 2019, the prevalence of hypertension reached 40%, with 53% of cardiovascular related death being linked to hypertension disease. Management and control of hypertension require both pharmacological and non-pharmacological intervention. There are a variety of non-pharmacological intervention for control and management of hypertension, including dietary modification, lifestyle changes, and change in physical activity level. Therefore, employing intervention.
Marzia, sorry for interruption. Are you moving the slides?
Yeah, you can see the slide. I'm on
you can see the introduction
part.
slide.
Yeah.
If you want us to share the presentation from our side, we can do so.
Yeah, you can share.
Okay. Ammar, can you please help us?
And I would also request the presenter to, I would also suggest that please focus more on your methodology and results, give more time to that, so that we would not miss any important thing due to the time limitation. So give your more time to the methodology and result section. Thank you.
Please go ahead, doctor.
Dr. Marzia, can you hear us? Dr. Marzia? I think she has some audio issue.
I think we lost her. Okay.
Is she present or disconnected?
She's disconnected now, yeah.
Okay, in that case, can we go with the next presentation? Approval.
Dr. Jamaluddin, yes. I'm checking if he's with us.
Dr. Jamaluddin is here with us from Afghanistan. Dr. Jamaluddin, are you with us? He is also mute. Dr. Jamaluddin from Afghanistan.
I can't see he's connecting. So maybe also he has a connectivity issue because he was with us.
We can wait for 1 or 2 minutes. they may be able to reconnect.
However, for
Maybe
our
we
next
can
presenter,
open the floor for questions for Abdulrahman Ruba.
yes, Dr.
the
Zakir.
meantime.
We have Dr. Marzia back, so maybe if she can
Okay,
continue.
Dr. Marzia, are you back? Hello, Dr. Marzia.
Yes, she's connecting her audio.
Okay, there is one question for Dr. Abdul Rahman is that one participant have asked that I haven't understand who chronic disease causes stigma, or which chronic disease is causing the stigma. Dr. Abdul Rahman?
Thank you so much. Can you hear me?
Yes.
Yeah, in Somalia, conditions like chronic liver disease and cancer are usually considered as a kind of a taboo or a kind of a curse causing disease. So some people, if they suffer from these conditions, they usually encounter with stigma in that particular disease.
Okay, that is considered is a curse, I think you mean.
Yeah.
Okay, thank you. So this was the only question for Dr. Abdul Rahman. So do we have Dr. Marzia back? And Dr. Jamaluddin
Dr.
Mudafi?
Marzia, yeah. We have her, yeah. Both are connected now, so let us check if they can hear us.
Yeah, Dr. Marzia, can you hear us?
Okay.
There is sound.
We have
So
Dr.
Dr.
Jamaluddin, if you want. Yeah.
Yeah, Dr. Jamaluddin Mudafi from
Yes, I'm
Afghanistan.
here. Yes.
Okay. So please, can you go ahead with your presentation on enhancing the awareness of policymakers about NCDs, a tsunami in Afghanistan, a health in all policy dialogue?
Thank you. Thank you. In the name of Allah.
Yeah, please
good
start. You
afternoon.
have 10 minutes, so keep the time limit in your,
Okay, inshallah. Inshallah.
Thank you.
In the name of Allah, good afternoon, respected audience, honorable professor and dear colleagues. This is Jamaluddin Mudafi, public health specialist, and I'm very pleased to be here today at this symposium to talk about one of the most important public health challenges in enhancing the awareness of policymakers about non-communicable disease tsunami in Afghanistan, held in all policy dialogue. The rise of this disease has become a serious threat to our society's health and required a multi-sectoral
We cannot
approach.
see your presentation, Dr. Jamaluddin.
Okay. Sorry.
Please share your.
I just share it. Presentation. Please, Mrs. Duhat, can you share my presentation? I cannot.
Yes, sure. Please, Ammar, share Dr. Jamaluddin presentation.
Thank you.
Yes, here you go, Doctor, please.
Okay, please next slide. Okay, the first non-communicable diseases or NCDs are now the leading causes of this and disability worldwide. They account for 71% of global deaths, affecting millions of people every year. Afghanistan, no exception. A recent estimated show the 75 to 40% of these in Afghanistan are caused by NCDs, such as cardiovascular disease, diabetes, chronic respiratory disease, and cancer. The rapid increasing in these disease is mainly due to modifiable risk factors, including tobacco use, unhealthy diets, physical inactivity, and alcohol consumption. Unfortunately, Afghanistan healthcare system is not well prepared to handle the growing burden of NCDs. There is a limited infrastructure, a shortage of trained professionals, and inadequate diagnostic facilities, making prevention and treatment even more challenges. Please, next slide. The next slide, our study objective. Main objective: enhancing the awareness of policymakers about NCD tsunami in Afghanistan, and in our study specific objective: increasing knowledge and awareness, strengthen multi-sectoral collaboration, capacity building, assess learning outcome, establish focal point for future intervention, and facilitate policy advocacy. Please, next. Okay, in our study, the method part, our study was designed as an implementation research project using mixed method approach. We conjugated a 3D interactive workshop to enhancing policymakers' awareness and capacity in addressing NCDs. The workshop was held in Kabul, Afghanistan, including representatives from 22 governments, ministries. Each ministry nominated 2 participants, resulting in total 44 attendants. For data collection, we used multiple tools. Workshop season covered key topics such as the global and national burden of NCDs, risk factor, and prevention strategies. Group discussion and participatory exercise helped participation explore their roles in NCD prevention. Feedback and review session ensured active management and content improvement. Pre-test and post-test assessment measured knowledge improvement. Please, next slide. For the data analysis, we used both qualitative and quantitative methods. Thematic analysis was applied to group discussion and feedback. Pilot t-test compared pre-test and post-test score to evaluate knowledge gains. Regarding ethical consideration, this study was approved by the Afghanistan National Public Health Institutional Review Board. And followed by ethical guideline for human research. Please, next slide. Okay. Our study main result, the key finding, our implementation research on enhancing policymakers' awarenesses of NCDs in Afghanistan. The first main result in our study, knowledge improvement. One of the most significant outcome of our study was the increasing in participants' knowledge about NCDs. Before the training, the average pre-test score was 75.7, indicate a moderated level of understanding. However, after the workshop, the post-test score increasing to 89.9, or also p-value equal 0.002. Demonstrating a significant improvement to knowledge. The result confirmed that the training effectively enhancing policymakers' understanding of NCDs, risk factor prevention strategies, and national policies. The second, the main result of our study, role of ministries. The study highlighted the important role the different government ministries can play to tackling NCDs. Some key contribute, including Ministry of Public Health, leading policy development, service delivery, and NCD management strategies. Also, the Ministry of Education and Higher Education, integrating NCD awareness into school and university curricula to promote prevention from an early age. Also Ministry of Agriculture, Irrigation and Livestock, promoting healthy food production and improve access to nutritious dates. Also the Ministry of Finance and Economy, allocating resources for NCDs prevention programs and reducing financial barrier for healthcare service. Kabul Ministry of the Finance also Kabul municipality and urban planning sector, creating healthcare urban environment by promoting physical activity and reducing pollution. This intersectoral collaboration is essential as NCD cannot be addressed by the health sector alone. It is requires a whole of government approach. Third, our main result of our study, key challenge identified. Despite these progresses, the study also identified major challenges that need to be addressed for successful NCD prevention and control. These challenges fall into the four key areas we mentioned. One, weak infrastructure. There is a lack of diagnostic facilities, trained healthcare workers, and specialized NCD service in many parts of the country. The two, economic barrier. High out-of-pocket costs and limited health financing make it difficult for many people to access necessary care. Three, demographic shift. Rapid urbanization and aging population area increasing to burden of NCDs, requiring urgent policy adoption. For an effective management, weak coordination between ministries, limited data availability, and lack of accountability hinder the implementation of effective NCD programs. Also, the main our result workshop evaluation. Finally, the overall the evaluation of the workshop was highly positive. Participants found the content relevant, the facilitation effective, and engagement highly attractive. The participatory approach, including group of discussion and problem-solving exercise, was especially valued as it allowed policymakers to share insight and develop realistic strategy for their respective sectors. Next slide, please. At the end, our study recommendation. Based on our finding, we would like to present key recommendation to strengthen Afghanistan response to NCDs. First, the strengthen intersectoral collaboration, improve coordination among ministries to ensure unified approach to NCDs prevention. Two, enhancing awareness and capacity building, conjugate regular training session to keep policymakers and healthcare professionals updated. Three, improve resource allocation, increase funding and infrastructure support for NCDs prevention and management. For develop a robust national NCDs strategy, establish a comprehensive evidence-based strategy tailored to Afghanistan needs. Five, policy advocacy for NCD prevention, promote stronger policies and tobacco control, healthy dates, and physical activity. Six, leverage the established network of focal point. Utilize a trained representative from each ministry to sustain long-term action. At the end, by implementation these recommendations, we can build a more effective and coordinated response to NCDs in Afghanistan. Next. Thank you so much.
Thank you, Jamaluddin, for a very nice presentation. Dr. Marzia is online?
Yes.
Yeah, Dr. Marzia, you can continue.
Yeah.
And please, you have done initial introduction slide, so go with your next slides from methodology to the results, please.
Can you please share the slide? Yeah, thank you. Bismillahirrahmanirrahim. Although the efficiency of using WhatsApp for the purpose of mobile health was established during COVID-19 pandemic, it is used in management of hypertension has been not studied, especially in the setting of Afghanistan. So we hypothesize that WhatsApp provide a free online platform and it could be used as a communication channel for increasing the self-care behavior of hypertensive patients through educational content. So our objective is that, please, next slide. Yeah, next slide. Yeah. Our objective is to enhance hypertension management in Kabul and to evaluate the effectiveness of WhatsApp as a platform for delivering hypertension education, to measure a change in systolic and diastolic blood pressure among patients, and also to assess improvement in medication and adherence and self-care behavior. Next slide. As this was an implementation interventional study that was conducted in 3 Kabul public hospital, Aliabad, Ibn Sina, and Wazir Akbar Khan, to find 5 outcomes of systolic, diastolic blood pressure and self-care behavior among the patients. Participants were selected from these 3 hospitals, and these patients were from Kabul and nearby province of Kabul, like Wardak, Parwan, and Logar provinces. The age category or the age range was from 35 to 70 years, and also we consider eligibility criteria for selecting of the patient. We use 2 questionnaires. One is Helbon compliance to high blood pressure therapy skills to assess a change in self-care behavior, focusing on sodium intake reduction, medication adherence, and appointment taking. And in addition, we develop a structured questionnaire to find out socio-demographic and medical history of the patient. Next slide. Our study was conducted in 3 phases. One were pre-intervention, that when we select the patient, we conduct the information by our field unit at the hospital. Then in the intervention phase, a team of experts developed the educational content and delivered in pictorial, video, and audio format through WhatsApp in a periodic time. After this intervention, we re-inform the patient to take appointment with their relevant specialist and collect the information on the post-intervention. After collect the data, we develop a database on the Excel, and data were entered in the database and cleaned due to loss to follow-up, and also data were analyzed as data using a descriptive statistic and percentage for the data. And also we find the relationship between demographic characteristic of the patient and also self-care behavior. And also at the beginning of the study, we obtained the IRB approval from Afghanistan National Public Health Institute. Next slide. Thank you. At the result from the primary enrollment of 101 patients, 91 were included in the final analysis, and 10 other patients were also lost to follow-up. Based on proportion of 6, nearly more than 2/3 of the study patients were female, and the age mean of the study participants were close to 55%. And also literacy was seen among 50.5%. From them, 84% were from urban area. And also hypertension was previously diagnosed among 95% of the patients. From them, 74% had comorbidity. When we analyzed the BMI level of the patient, nearly 2/3 of the study, 1/3 of the study participants had the BMI of over 30. Please, next slide. In the bivariate analysis, the mean outcome variable were tested for the difference observed, and the systolic blood pressure and also the diastolic blood pressure of participants was significantly changed and after the intervention. And also the average score of reduction among and medication adherence was respectively improved among the participants after the intervention. Appointment taking score was not significantly changed, so it is not included in the final analysis. Please, next slide. According to our result from a demographic characteristic, previous diagnosis of hypertension, presence of hypertension among first-degree relative, previous of antihypertensive medication was significantly relative with the sodium intake reduction. And also presence of comorbidity was significantly association with the medication adherence. This study report a statistical significant association between the presence of comorbidity and medication adherence increased after the intervention. Other socio-demographic characteristic like literacy level had not significantly association with the self-care behavior, so it was not included in here. Please, next slide. The 5-week WhatsApp-based educational intervention significantly reduced both systolic and diastolic blood pressure, and also the intervention enhanced self-care behavior, particularly in reducing sodium intake and increasing medication adherence. And also a small and periodic patient education content through WhatsApp provide a comprehensive platform of health promotion. And also smartphone application offer potential for scalable non-communicable disease health intervention in Afghanistan. Please, next slide. The finding of this study could serve as a stepping stone for the next intervention based on a smartphone application for management of other non-communicable diseases. WhatsApp can significantly improve self-care behavior and clinical outcome among hypertensive patients. Through a 5-week intervention, participants experience education in systolic and diastolic blood pressure, improvement in sodium intake reduction, and also medication adherence. According to the finding, our study recommend on 3 points. One is to better understand the full potential of mobile health intervention. A future study should conduct a longer intervention for a broader population and diverse digital platform. Another is integrating mobile health intervention into national public health strategy could improve chronic disease management in Afghanistan, and also healthcare behavior can incorporate a mobile health strategy on their routine activity and deliver educational material or content or counseling for their patient for improving self-care behavior of the patient. Next. And the last, I'd like to extend my gratitude to Eastern Mediterranean Public Health Network, our teacher, Dr. Sahib Khaja Mir Islam Saeed, and also Dr. Sahib Shuaib Naimi, and also the Afghanistan National Public Health Institute, 3 specialist doctors from 3 hospitals, Aliabad, Ibn Sina, and Wazir Akbar Khan, and also my respected colleagues for collaborating me on this study. And also thank you from you for being me the chance to share the study result with you on this important symposium. Thank you.
Thank you, Dr. Marzia, for very informative presentation. So now the time is for question and answers. We have 7 to 10 minutes for this purpose. And first, I would read some questions I can see on this QA board. Dr. Mirwais Amiri has asked Dr. Jamaluddin that how can you translate your recommendation into the most appropriate interventions in a whole of government approach for an effective NCD prevention? Dr. Jamaluddin.
Yes, I am here. Thank you, Mr. Amiri, for your nice
Could you
question.
also respond to the question raised by Dr. Amna Khairi? So these two questions are actually related to you.
Okay. To answer the question for Mr. Amiri, to make the recommendation effective, we need all government sectors to work together. For example, the Ministry of Education can promote healthy lifestyle in a school. Also, the Ministry of Agriculture can support healthy food production, and the Ministry of Finance can tax unhealthy products like tobacco. Coordinated approach will help prevent NCD more effectively. Thanks.
And the second question is regarding any plans to measure the impact of the intervention, the workshop, stakeholder engagement mechanism on the NCD control in Afghanistan.
Okay. Yes, we plan to measure the impact by tracking policy change, monitoring NCD-related programs in different ministries, and assessing long-term improvements in awarenesses and collaboration. We also regular follow-ups and evaluation will help us see the progresses and make necessary adjustments.
Thank you, Dr. Jamaluddin. Now, there are some questions for Dr. Marzia's presentation. Did you also use WhatsApp for appointment of your included study participants? Dr. Marzia. Dr. Marzia, can you hear us? Hello? Dr. Marzia, are you there? Dr. Marzia?
Yes.
Yeah, there are some questions on your presentation. Can you hear me clearly?
Yeah. Yeah.
So one question is, did you also use WhatsApp for the appointment of your included study participants?
Yes. Yes, we also use WhatsApp. We make a group among our team, and also for the follow-up of the patient and follow-up of the doctor, we use a different group at WhatsApp.
So you use that for the study participants.
Yes.
Okay. The second question is any figure on internet usage in Afghanistan? That how many, what percentage of people using internet in Afghanistan?
Up to date, according to recent study, the prevalence of usage, I think 20 to 30%, and incidence in any fresh data is not available, I think.
Okay. You mean there is no current data available?
Yeah.
For this use of internet in Afghanistan. Okay, that's fine. So now with this, the second session for NCD is concluded with these three presentation. Dr. Ruba.
Thank you so much, Dr. Zakir, and thank you for the presenters. So moving to the next two presenters from Iraq, I'd like to invite Dr. Salma Afifi, Senior Technical Officer of the MFNET Egypt office, to facilitate these two presentations. Please, Dr. Salma.
Yes, in this session, which is talking about the physical activity and lifestyle of people, of students in Iraq. We have two presentations. The first presentation will be presented by Dr. Tamara Al-Amri from Babylon Health Directorate, Ministry of Health, Iraq. And she will present a study entitled Assessment of Lifestyle and Physical Activity Among University Students in Babylon Province, Iraq, a cross-section study 2024. Is Dr. Tamara here? Dr. Tamara?
Yes, Doctora.
Please, the floor is yours.
Thank you.
Do you want us to share the presentation, or you'll be sure? Okay.
Assalamu alaikum. First introduce myself. My name is Tamara Shihab Al-Amiri from Babylon Governorate. I belong to Ministry of Health from Iraq, graduated from an intermediate FETP quarter 3. First, I will talk about my topic. My voice is clear, okay?
Yes.
Thank you. My topic is about assessment, lifestyles, and physical activity among university students in Babylon province in Iraq. Our study is a cross-sectional study occurring 2024. First, we begin with background. In recent years, lifestyle have rapidly changed due to the availability of high fat and high calories food, and telecommunication devices such as smartphones, social media. According to WHO, recorded in sedentary life, as we know, the inactivity or in latent life lead to several factors that cause mortality and cardiovascular disease, obesity, diabetic, depression, and anxiety. The physical inactivity linked with two main causes of death, 7% for cardiovascular disease, and 7.2% for death for all cases worldwide. Also reported in WHO of increased incidence of non-communicable disease like DMCA, cardiovascular problem, inflammatory disease, increase in morbidity and mortality. The lack of physical activity has become a fourth leading death or mortality in all world. Such studies or literatures that can be useful for beneficial role of physical activity in health living and preventing managing a health disorder. All that will document it, and we can use the social media and the paper PubMed for appear the beneficial role of physical activity. We have two main objects of our project. The first one to assist student practice healthy lifestyle behaviors. The second one to identify the factor contributing to unhealthy behaviors among the students in Babylon University. Now we talk about our methods. Study design is analytical cross-sectional study. Study population, all students that enrolled in first stage of Babylon University in selected college. Informative technology, that the college that we used in our survey. Informative technology, engineering, medicine, nursing, humanitarian science, and basic educational. Sample size is about 600 participants, 100 for each college. The study duration is conducted between February to August 2024. The data collection is about a questionnaire. The questionnaire was self-administrated and structures, consists of 5 parts. Each part have topics and a question to it. Part 1 is about demographic. Part 2, physical activity habits. Part 3, lifestyle and habits. Part 4, fast food consumption, and part 5, tobacco consumption. We start with method. Data analysis. The collected data was entered and organized by using Microsoft Excel, analyzed by using SPSS 26 version. Resulted with count with frequency, means with the standard deviation. Also, we use table and graphs. Ethical approval. Ethical approval was obtained from University Institutional Review Board and obtaining informed consent from all participants for anatomy and confidentially. That's all we talk about the method. Now we begin with our results. A result that's defined with a total 590 participants of college students, only 509 that complete our survey. The mean age is 20 plus minus 2.5 year, with median age is 20 year. The female have the larger proportion, consists of 54% in our study. The physical activity in majority of students, 26%, that's represented the only 1 day physical activity per week. The other physical activity, 2 to 5 physical activity per week, is less than %. Highly significant proportion of students by male have a regular physical activity than female. Is about 56%, with p-value is less than 0.001. The mean duration of sleep. Now this result, the first 4 results, is about the assessment of a practice for students. Now with the objective 2, about the factor that contributing in unhealthy style. First, we begin with sleep disturbance. Now, the mean duration of sleep per day is reported about 7.6 plus minus 2.5 hours. While alcohol consumption, there is no significant relationship with demographic like sex, density, or college. We still with the results. The third factors with unhealthy fast food. We know that 70% participating students reported with once per week that consume fast food. The 30% still between 2 to 5 days per week they take fast food. Now we talk about the smoking consumption, highly significant differences between male and female. We know that highly consuming by male, with p-value less than 0.001. These figures show about the daily cigarette smoking per year. The figures show that 39% the daily cigarette smoking consumption by male is between 1 to 5 years. The least one consumption per year is 17%, 5 to 10 years. Now, we're still with the result, the approach of quitting tobacco demonstrated that showed that the quitting tobacco, a high percent with appropriate stopping, 54%. The last one is the prescription medication, 1%. The others, 90%, is included the situation, habit, or the status of the student that enrolled in our study. Now, with our recommendation, the recommendation highlights a need to have college-based healthy lifestyle intervention program. Thus, by established places for the student to make environment prepared for exercising. It is necessary to undertake strong information about on the positive influence to become more healthy and fit. The greater health promotion needed to increase awareness for current guidelines and promote physical activity participation. The future studies, we're looking for that, two main topics. The first one is improve lifestyle and dietary habits, intervention improve. And the second one, explore of a specific concern about the obesity and related factor. Finally, we're thankful for the Infinite and GHD for many grants funded, also for Babylon Health Directorate Manager of Public Health, and also for Manager of Epidemiology Section, Dr. Yasser Majid. And of course, for University of Babylon that supports our project and complete with the timeline. Thank you for listening. That's all. Thank you.
Thank you, Dr. Tamara Lawi, for this interesting results. I'm wondering, because you have selected the first year, and you said that some of them are having started smoking 5 years ago. So this is very interesting to notice or to investigate. Now, I will leave the discussion to the end of the session. The second presentation will be presented by Dr. Bilal Jawad. He will present the cigarette smoking and its associated factors among students also at Babylon University in Babylon Province, Iraq, 2024. Dr. Bilal is here. Dr. Bilal? Dr. Bilal
Yes,
Jawad?
Dr. Sam. Yes, Dr. Sam.
Yeah. Please,
Assalamu
the
alaikum.
floor is yours. Alaikum salam. The floor is yours. تفضل.
Are my presentation is clear?
Yes.
My name is.
If you can select the presentation mode, please. If not, we are okay. We are fine.
What?
Please select the presentation mode.
Yes. Okay.
If you can. It's okay. Please go ahead. Yes, thank you.
My name is Bilal Hadi Jawad. I work at epidemiology section in Public Health Directorate under Iraqi Minister of Health. My presentation, my project is cigarette smoking and it is associated factors among students at Babylon University in Babylon Province, Iraq, 2024. Smoking remains one of the most significant global risk factors for disease and mortality. Tobacco smoking reduces life expectancy, increase overall medical costs, and contributes to loss of productivity during the lifespan and lifespan of an individual. Substance abuse among university students, including smoking, is a frequent issue and a major public health concern. Epidemiological studies among different university student population in Arab and Eastern Mediterranean countries demonstrate a marked variation in the prevalence of smoking. There is limited recent data on smoking prevalence among university students in Babylon specifically. Objectives of my project: to determine the prevalence of cigarette smoking among students at Babylon University, and to assess students' knowledge of the health risk associated with smoking. Also, to identify the factors contributing of smoking behavior among students. Method: study design, analytic cross-sectional study. We conducted this study. The study time conducted between March 2024 and August 2024. Population: all students from the selected college within Babylon University were eligible to participate, ensuring a comprehensive examination of smoking behaviors across different fields of study. To achieve this, structured sampling strategy was implemented, beginning with the selection of college and followed by the selection of students within this college. This was sampling in the first stage. In the first stage of sampling, stratified approach was employed. The public university in the Babylon Governorate were categorized into three strata based on the type of academic discipline. A simple random sample method was then used. Randomly selected 6 college participating in the study. Simple random sampling method was then used to select 100 students from each of the chosen college, ensuring a representative sample from each academic discipline. Sample size: we use API Info 7 statistical software was used for the estimation of the sample size. Sample size include 642 participants with 629 fully completing the survey questionnaire. We use self-administrated structure questionnaire. The questionnaire consists of 3 parts. The first part, demographic characteristic of the participants, have 12 questions. The 2 parts about knowledge about the health effect of smoking with the 8 questions, and 3 part tobacco consumption habits among current smokers and former smokers was with the 11 questions. Data analysis: data were checked for accuracy and completeness regularly. The collected data was entered and organized using Microsoft Excel 2021 and analyzed with statistical package for social science version 26. Descriptive analysis were performed and the result were presented as count with frequencies and means with the standard deviation and appropriate in the table and the graph. Person chi-squares or Fisher exact test was used to compare categorical variables between groups with p-value smaller than or equal to 0.05, considered statistically significant. To maintain data quality, questions with non-response rate of more than 80% were excluded from the analysis. We take the ethical approval before the beginning of the project from the university institutional review board. Result: the study included 629 participants with mean of age 21.5 and standard deviation 3.3. The largest age group was in 21 years with 45% and 55% were females. Among those participants, 18.7% of were smoker. Regarding the association between demographic variables and smoking, there was a significant association with age group, sex, campus. There was smokers in the family. Among those have smokers in the family, the highest percentage of participants have fathers was a smoker. Characteristic of smokers among students regarding type of tobacco use, 18% with cigarette smoking, 56% with hookah smoker, 65.1% with electronic cigarette smoking. Among those with electronic cigarette, there was 62% use it daily. And regarding how many cigarettes do you consume per day, the highest percentage among categorical, 29.5% regarding 11 to 20 cigarettes per day. Duration, regarding duration of smoking, 38% with more than 5 years. And for reasons for smoking, 13% was to pass time. Distribution of study sample according to knowledge score. The highest, most of participants with good knowledge about the health effect of smoking. Association between smoking behavior and knowledge was significant at p-value 0.01. The highest participant with non-smokers have good knowledge. Distribution of study sample according to methods of strategy. There was 81.9% with concerning or support group. This strategy used to try or to quit or reduce smoking. Recommendations: comprehensive educational program to raise awareness about the health risk of smoking, particularly targeting younger students and adolescents to prevent the initiation of smoking. Future research should aim to include more diverse samples from different universities and regions to ensure broader applicability of the results. Additionally, longitudinal studies are recommended to track change in smoking behavior over time and assess the effectiveness of intervention program. Finally, I would like to extend my sincere thanks to INFNET to providing many grant fund and support. Thanks for Dr. Ruba, Dr. Randa, and others to guide us to completion the project. And also thank the epidemiology department in the Ministry of Health. Also, thanks for our team in the epidemiology section and the Public Health Department and Babylon Health Directorate. Thank you for listening.
Thank you, Dr. Bilal, very much for the interesting and very informative presentation. I don't see any questions on the Q&A, but I have questions for you and also for Dr. Tamara. I just wanted to know the methodology that you have collected this information. Was this an online questionnaire, or was it a paper form that was distributed and then collected after how many days? I don't know. So, and the same methodology for Dr. Tamara. So please clarify this point. Dr. Bilal and Dr. Tamara, how were the data collected? Was it an online form or was it a paper
Not
form?
online.
Was it? It was a paper form?
Face-to-face questionnaire, face-to-face administered questionnaire.
Self-administration.
Self-administered?
Yes, I mentioned that in methods.
Yes.
Self-administration structures questionnaire that interview and consist with the anatomy and confidentially from the participant. Then we contributed the questionnaire to the students who agreed to involve to our survey.
Yes. Another question is how many of these smokers tried to quit smoking? Did you ask this question? How many of them tried to quit, and how many of them succeeded?
I mentioned that in my results.
Yes.
Can I share my
Yes,
screen?
please.
The quitting tobacco demonstrated that in figure, which one? Total numbers is 40.
Yes.
As that's shown the figures. Only 40 from all participants that's quitting the tobacco.
So
that's the question about how many quitting?
Yes, yes.
And numbers is 40.
So 40 have been quit.
From 519%.
Yes.
Person or that participant in our study.
Half of them they stopped abruptly without
Yes.
help. Yeah.
Yes.
Thank you.
Dr. Salma, regarding my project,
yes, please. Yeah, Dr. Jawad.
89 regarding my project, 89 participate tried to quit or reduce tobacco consumption. With the 30% among those who smoking.
Last question for you both, my dear colleagues. Do you think the smoking is a problem in the university or in the youth in Iraq?
Of course, it's not only for Iraq, it's for all the worldwide.
Yes, I know.
It's a problem, especially the electronic.
Yes.
That's make a problem from the early age. We shown the secondary schools, the high schools, increase the numbers of students or participants with the tobacco.
Yes.
So can cut it.
Yes. Dr. Jawad, if you want to say something before we conclude our session.
Can I ask you a question, please?
Yes. So thank you,
Dr. Mer raised his hand.
Okay, thank you very much. Thank you. I had a question regarding the rules and regulation in Iraq regarding restriction of smoking. I mean, is there the schools, universities like Babylon and other smoking free, or the young people, the residents, the students are allowed to smoke in such educational areas? What's the rule and regulation? Thank you.
Yes, of course, there's rule and restricted a lot, but a lot of them is especially to my project. We take only the first stage. They come from the secondary school, so they began the smoking from the second primary and secondary school, and from 12 years he began to smoking. So he admitted to using that. In college, restricted in educated or training halls, but there's specific places in every place for their smoking. But we can cut it in يعني financially or إيش هنقول we can cut it off to they take smoking. دكتور بلال إذا عاد إضافة.
No, I don't have any.
So thank you, Dr. Tamar and Dr. Bilal, for their very nice and informative
You're
presentation.
welcome.
And this will conclude our session on the smoking and physical activity. Thank you.
Thank you very
so
much. Thank you for everyone.
Thank you, Dr. Salman. Thank you for the presenters. Now, last but not least, we're moving to the last two presentations from Bangladesh. We have Dr. Islam Saeed, our technical advisor for Afghanistan FETP. So please, Dr. Saeed, to introduce the speakers.
Thank you very much. Thank you, Roba. And fortunately, we have both presenters available. This is the last session, but not the least. I assure you that it will be a very good and interesting session, the last couple of presentations. We have two presentations from Bangladesh, and the first one is regarding a strengthening passport to mental health, integration of mental health assessment screening tool in routine postnatal care. I'll request Dr. Fujul Islam from Bangladesh to deliver their presentation. You have just 10 minutes for this presentation, and I request all the audience to write their questions in the QA portions which is there in order to have a discussion. Floor is yours, Dr. Fujul Islam, please.
Thank you for allowing me to present my research project, distinguished faculties, participants, and attendees. Myself, Dr. Mohammad Fajul Islam, an FETP fellow, currently working as a medical officer in Institute of Epidemiology, Disease Control, and Research, Bangladesh. My research topics is strengthening postpartum mental health and integration of a mental health assessment screening tool in a routine postnatal care. So, postpartum depression is the most common psychological condition after childbirth, and it significantly impacts the mother's, newborn family, and their communities. And the critical period of the development of the postpartum depression was considered in the first 6 weeks, but this could be extended up to 1 year due to the hormonal and anatomical changes that happens to the women, and in the severe cases that may be lead to the postpartum psychosis, suicide, and infanticide. There is symptoms like sadness, mood swing, and hopelessness for morning, and then baby sleeping about disturbance, guilt, and thought of the self-harm. It's affected to 15% of the mothers globally, with a wide variation like 0.5 to 60.8% based on the geography, income, and ethnicity. High prevalence are shown on the South Africa and Southern Asia, but in Bangladesh, there is 18 to 35% prevalence in rural area, and there is the yet minimum research and policy focus. What are the challenges in Bangladesh to regulating postpartum depression? There is the limited screening and diagnosis, and the reporting by the postpartum care provider, and lack of the routine mental health assessment in the postnatal care. So the proposed solution is the integrating of the Edinburgh Postnatal Depression Scale, EDP scale, which is a screening tool for the postpartum depression, and a simple screening tool that have a high sensitivity and specificity, and it facilitates early detection and intervention regarding postpartum depression. So, impact of adopting EDPS is identify high-risk mother efficiently and raises awareness among the policymakers and strengthen postpartum mental health care. So, what is the rationale for the conducting this project? Because many women with mental health issues remain undiagnosed, there is some barrier like stigma, lack of awareness, and fear for healthcare seeking. Rural women lack knowledge about the postpartum depression, and the maximum time they have no available support from the family. So there is very little opportunity for the routine screening and diagnosis. So if you can implement this in the routine postnatal care, this can give us a cost-effective, simple tool to early diagnosis and helps uh, women uh, women to identify their depression and postpartum psychosis and to minimize the long-term distress, ensuring better maternal mental health. So what is the goal of our project is to integrate and assess the impact of the mental health screening tool in the routine postnatal care for early identification and support of the postpartum mental health issue. We specifically see that determine the proportion of the PPD using by EDP's tool, identify the socio-demographic factor associated with the PPD, and assess the reproductive factor contributing to the PPD and other pregnancy-related factors influencing the PPD, and evaluate the impact of the early screening on timely intervention and support the services. So this is a cross-sectional study. Study period was 8 months from February to September 2023. Study basis, we selected the 3 tier of hospital: 1 primary care healthcare facility, 1 secondary healthcare facility, and 1 tertiary healthcare facility. We selected the women, those have from 4 to 12 weeks after delivery, and we selected 540 participants to 180 from the East type of facility, and the sampling technique was purposive. So we selected women, include the women, those have postpartum women within 4 to 12 weeks after delivery, women with an alive baby, and those attending the routine postnatal care. And we excluded the women with previous history of the postpartum depression or any psychiatric illness, having any non-chronic disease, infant death, or newborn with severe illness. The EDPS tool is a validated tool, but we translated it into Bengali, our local language, and then this is reviewed by the expert panel from the gynecology, psychiatry, psychology, and public health. And this screening tool have 10 questions, and if the score is more than 10, this is described, this may have probable postpartum depression and seeking mental health. We train postnatal care nurses, and also we recruited data collector. They aid the nurses to assess EDP's tool by face-to-face interview, and also we did the weight and height from them by a standardized method. So we uses the software strata for the analysis, and we conducted the descriptive statistical summary, socio-demographic reproductive data, and also inferential statistics like the for categorical variable chi-square test, and also ran a multiple logistic regression method to assess the factor for development of the postpartum depression. So we found the prevalence of the postpartum depression among the study participants is 48%, and the severe postpartum, that means the ADP score is more than 13 in 29% cases. So there is no significant difference between the prevalence among the type of facilities, and also there is no significant difference between the severity of the postpartum depression among the different tier of facilities. So when we're going to identify what are the factor behind the development of the postpartum depression, we found that the women, those age more than 30 years, they have 1.28 times more chance of development of the postpartum depression. Those who have a previous history of the depression, they have a 3.23 times more chance of development of the PPD, and those women have the menstrual irregularity, they have also 3.51 times more chance of development of the postpartum depression. Those who have the history of abortion, they have also 1.71 times chance of the development of the postpartum depression. And those women who have perceived their pregnancy time as difficult by a self-perception about their pregnancy and delivery time, they have also more chance of the development of the postpartum depression. According to our EDP screening, we recommended the women for consulting to attend a psychiatric consultant after referral by the facility. And then after 14 days, we called them to collect their information and found that in the medical college hospital, the higher number of the patients have attended, 48.98% attended for a psychiatric consultant. In secondary secondary healthcare facility like maternal and child health facility, there 33% have attended for the referral, and a minimum percent, 23% from the primary healthcare facility have attended for a psychiatric consultant. So postpartum depression is a common mental health issue affecting the women after the childbirth. And our study utilized a different tier of the facilities, and we determine the prevalence, severity, and associated factor, and we give them some recommended. So what is the concern? There is a high prevalence of the postpartum depression, and 29% have the major PPT. And there are the previous study in the Bangladesh conducted. They found in Dhaka 29.9%, some rural area 20%, and urban some 39.4%. These are the our finding is higher than that, and higher prevalence than the global estimate also. Some developed countries 6 to 30% compared to India, but in developed country there are some countries more than us, like 48 to 54%. So we determine that those women have the higher age, more than 30 years old, they had higher PPD risks, and some reported factor like abortion, menstrual irregularity, also a higher chance of development of the postpartum depression. And unplanned pregnancy also comorbidity was significantly associated, and those women who get family support and receive their pregnancy and delivery easy, they have less chance of development of the postpartum depression. So we recommended that this EDPS tool could be integrated in the postnatal care, particularly in the primary care setting. And the targeted group could be the older mothers, those have a previous depression and pregnancy complication, and stronger referral system to ensure psychiatric follow-up, especially in the rural area, and enriching family and social support to mitigate the postpartum depression risks, increasing awareness and screening in all healthcare facilities. So we can conclude that there is a high prevalence in our country that needs to urgent need for the integration of the EDP screening tool in the postnatal care for early detection. The key risk factors are age, prior depression, reproductive health issues, pregnancy perception, and there is a low psychiatric consultation taken by the screen positive women, and we need to strengthen our referral pathways and mental health services and integrate mental health screening into the routine postnatal care by the policymaker. This study has some limitation, like this is a cross-sectional design, and we cannot follow up the patient for the future time. So these studies funded by the operational and information research from the Global Health Development, Eastern Mediterranean Public Health Network. I acknowledge their support, and I also support my investigator, Dr. Shiraja Monira, Dr. Fajih Ahmed Jaki, Dr. Tasnuma Mari, and Dr. Ahmeda Shirin, and Professor Mahmoud Rahman, and all the facility and their staff, those help during my field work. Thank you. And I'm concluding by saying a study, a picture from the data collection site. Thank you.
Thank you very much, Dr. Fajul Islam. Take in mind that that's a coincidence that I am Mir Islam and you are Fajul Islam. We have parts of our name are same, and we are coincidence that we are together, and that's a good coincidence. Thank you very much. We will just go to the Q&A and see the questions after this session. In the last presentation, you will have chance in order to have discussion over the question. Now I'll request Dr. Sabrina to present her presentation. The title is Direct Adherence Among the Patients with Hypertension and Diabetes Attending at Non-Communicable Disease Corners at Sub-District Hospitals in Bangladesh. That's also recent, last year, 2024. Dr. Sabrina, you have 10 minutes. And after that, we will have question and answer for discussion. Thank you. The floor is yours. We don't have your voice.
Hello. Assalamu alaikum. Can you hear me?
Yes, very clearly. Just maximize your slides and go.
Assalamu alaikum and good evening. I am Dr. Sabrina Mohna, Fellow of Field Epidemiology Training Program of Bangladesh. Thank you for giving me the opportunity to present my study in front of you, and thanks a lot GST FNet for selecting me for the mini grant. My study is on drug adherence among the patients with hypertension and diabetes attending at the non-communicable disease corners at sub-district hospitals of Bangladesh in 2024. Facing some difficulties. Hello? Can you hear me? Hello?
Yeah, you are there in your slides also. Just go ahead, please.
Okay. Hypertension and
No
diabetes mellitus are the prevalent non-communicable diseases globally and also in low and middle income countries like Bangladesh, contributing significant morbidity and mortality, that is 71% globally and 70% in Bangladesh of total death. So the Director General of Health Service established non-communicable disease corners at the sub-district hospitals with the help of WHO in 2013 to address this growing burden of NCDs, especially the hypertension and the diabetes. The study examined the medication adherence among diabetic and hypertensive patients in the sub-district hospitals to assess the socio-demographic factors, prescribing and dispensing practices, and adherence barrier. Here are my objectives to describe the socio-demographic characteristics of the patients reporting at the NCD corners, to examine the prescribing and dispensing practices, to assess the proportion of medication adherence among the diabetic and hypertensive patients, and to explore the factors contributing to medication non-adherence among the patients with diabetes and hypertension, and also to find the association between the potential factors and medication non-adherence among the patients with diabetes and hypertension. This was a facility-based cross-sectional mixed method study. Duration was 6 months. From our location was the NCD corners of 4 Upazila Health Complex of a southern district of Bangladesh, Gopalganj. Our population was the hypertensive and diabetic patients above 18 years who are reporting at the NCD corners of these sub-district hospitals. For data collection, we used the structured questionnaire, face-to-face interview, and focus group discussion. The tool used for this study is the Morsky Medication Adherence Scale 8. Our total responded was 301. Among them, the diabetic patients was 93, hypertensive patients 114, and patients having both diseases was 94. And in gender-wise distribution, the female participants were higher in 76.4%. The low adherence was slightly higher in the females than the males also. The females having the 57.8%. Our overall low adherence rate was 57%. Patients with both hypertension and diabetes had higher moderate adherence, that is 46.81%. And patients having the disease duration more than 10 years, having the moderate adherence, and patients living more than 5 kilometers of the NCD corners had the higher low adherence. Here I'm presenting the factors affecting the adherence. The common reasons for low adherence, we found that the medicine unavailability, that is 39.5%, which is causing 5.87 times more likely to result in low adherence. In the socioeconomic constants reasons are 33.7%. 45% of the patient reported missing doses due to work stress and long working hours and associated with the better moderate adherence, that is 57.1%. Among the socioeconomic reasons, the housewives had the highest low adherence, and that is the 2.62 times more. Low adherence was found highest among the income group of 15,000 to 30,000 BDT income, that is 59.5%. And reasons for missed doses was the drug unavailability, that is 77.3%. And the last reason we found the partial prescription fulfillment, that is 26.7%. Here we found that 80% of patients who receives some drugs with incomplete doses had low adherence. And those who receiving all prescribed drugs had better adherence, that is 70% moderate adherence. Here I'm showing the Decomatous responses of the Morisky medication adherence scale 8. Our general conclusion was the most respondents experience occasional difficulty. Many are able to remember their medication regimen consistently. 85.7% of the respondents took their medication yesterday during our study period. 63.5% of the respondents reported not missing any doses in the past 2 weeks during study period, and 36.5% of the respondents had missed doses in the past 2 weeks. Cause of medication discontinuation, we found that 8.6% of the respondents discontinued their medication without consulting their doctors, and 14% of the respondents stopped their medication when they feel better. During travel, 32.2% respondents sometimes forget to bring their medication when traveling, and 67.8% do not face issues remembering medication while traveling. For perception of medication routine, 22.6% respondents find the daily medication routine was inconvenient for them, and 77.4% do not find the daily medication routine bothersome. Also, there are some reasons like difficulty remembering medication. Among them, 45.9% of the respondents sometimes have the difficulty to remember their medication routine, and around 30% never or rarely struggle to remember their medication. Our qualitative part finds that healthcare providers' perspective was the inconsistent medication adherence was 87.5%. Challenges with the drug availability, 75%, and limited patients' education and counseling, 50%, non-disclosure of medication adjustment, 50%, and impact of distance from the NCD corner was also 50%. And patient perspectives, here we found the forgetfulness and intentional non-adherence, unavailability of the drugs as well, misconception about the disease control, frustration with daily medication, and also distance as a barrier. And our recommendation was the targeted health education program for the housewife, as the female participant was the higher, and among them the housewives are the higher in number. Appointment flexibility for more convenient follow-up schedules, drug availability to ensure the consistent supply of the essential medication at the NCD corners for the diabetic and hypertensive patients, and also participation fulfillment to improve the distribution of full prescription doses. Thank you all, and my heartfelt gratitude also to my director of IDCR, my institute, Professor Dr. Tahmina Sheen Madam, and also my mentor and my supervisor, Dr. Mona Lisa. Thank you all for your patient sharing.
Thank you very much, Dr. Mona, and thank you, Dr. Oyul Islam. And we have now just 7 to 10 minutes for discussion about the question. I don't see these are too much questions. Just regarding the inclusion and exclusion criteria for Dr. Islam, is there a question? What was the inclusion and exclusion criteria? But you mentioned the inclusion exclusion criteria in your slides. I was watching that one. But my question is regarding this inclusion exclusion criteria. You excluded the patients who are not coming to the healthcare facility, and also those whose they have not a live birth, you have excluded. Those who have live births, you have included. And what was the reason for this exclusion?
Because
To my opinion,
okay,
those who childs are missed or childs are not alive, they are in a bad mental situation as compared to others. It
okay.
will
Right.
underestimate. Please go ahead.
Thank you for your nice question. We have decided through this by three things. One is through previous literature review. And when a child is on the ICU or critical care, or a mother loses a child, she may be develop depression due to these causes. So we want to know that if this mother have postpartum depression, this is related to his first child. So we excluded other confounding factor like depression from child death, depression from any other thing like any other.
Thank you. Thank you very much, Dr. Islam. There's another suggestion for you. I mean, if you continue conducting this study this was like quantitative study. If you continue with a qualitative study and do based on phenomenology design in order to go for root causes of these anxiety and depression or mental health problems for ladies after postpartum depression, it will be a good design for you in order to find the root causes of the diseases. And that was just a comment. No, if you want, you can comment on this one. And also for Dr. Sabrina, the quality of healthcare facility also will affect the adherence to the medication. For example, from different perspective, different dimensions of quality. For example, when the person is respected in the healthcare facility, when the amenity is very good, when there is a good quality drugs are available, when the person is cared rather than providing care. These are the different aspects of quality that the patients will adhere to taking their medications. And I don't think, did you take these issues into account when you conduct this study? Thank you. Are you available, Dr. Sabrina?
Yes, I'm hearing. Can you repeat the question, please?
The question is regarding different aspects of quality for adherence. For example, amenity, for example, good technical medical doctor in the healthcare facility, for example, good medication, good quality medication, different companies. People are adhering to these issues. For example, the patient should be respected, the patient should be cared. In that case, they will adhere to medications. And otherwise, if we don't have good behavior, they will not adhere to the treatment facilities and also to the medication. What's your comment?
Thank you. Thank you. Our government is trying to provide the best quality medication for the diabetes and hypertension. Actually, the NCD corners currently now addressing only the diabetic and hypertensive patients, and the medication supply is only regarding that for the hypertensive and diabetic patients. And the maximum drugs providing in there is produced under national supervision. So I think the quality of drug is checked well, and that is actually trying to serve properly to the patients of the NCD corners. But due to some reasons, sometimes there is poor supply or not timely supplied medication. For that reason, the medication adherence hampered we saw in our study. But the patients are very much encouraged to take medications, treatment, diagnosis, as our NCD corners are providing all of them, the counseling, the medication, the treatment, and investigations all. And that is free of cost.
That's good. That's good initiative, and I hope that will be scaled up at the national level. And Dr. Islam, there is another question from Dr. Amiri to you regarding the screening. I mean, he's asking for a PhD integration of this issue, and also while conducting the EPDS tool, did you spot any false positive screening? And also, while EPDS is a very practical tool, and what's your thought about possibility of false negative results? I mean, in the tool, when you evaluated the tools, what was these two aspects of implementation of this tool?
Thank you. In Bangladesh, there is a scarcity of the qualified psychiatrists. So it's not feasible to detect postpartum depression by qualified psychiatrists in every stage. So if we can introduce any screening tool that is less cosmic. In this screening tool, which was used by me, was Edinburgh postnatal depression screening tool. These have only 10 questions, and it requires only 5 minutes to collect the information from the participant by face-to-face interview. So if we'll introduce this, it can be thrown by any trained nurse, trained public health, trained healthcare provider. So we don't do any psychiatrist to evaluate this. And all the screen positive women will be brought up for a psychiatric evaluation to the referral center. So if we integrate this to the routine postnatal care, so women come for the postnatal, then we will just only add this tool, only the 10 questions we will get who are in the risk of development of the postpartum depression. And this high risk group will directly refer to the higher center for psychiatric evaluation. Then the psychiatrist will decide about the treatment and management. Thank you.
Thank you very much, Dr. Ram, and also thanks, Dr. Sabrina. We are coming to the conclusion of last session. Thank you very much from both of you, and thanks from all the audience. Back to you, Dr. Roba, for last conclusion. Thank you.
Thank you all for your patience hearing.
Thank you, Dr. Sabrina, and thank you, Dr. Islam, and for all the audience who stayed with us for this long time. So before we conclude, I'd like to invite Dr. Randa again to share with us her closing remarks.
Thank you, Ruba, and thank you all distinguished colleagues, the esteemed researchers and presenters, and of course, all of our valued partners. Really, as we conclude today's symposium, I just want to express my sincere appreciation to all of the hard work that you have put into your projects, and I want to thank everyone for their active participations, for the questions that you asked, and really simply your commitment to advancing public health research in our region. I think the symposium today was able to provide a platform for some of the FETP residents and graduates, and as well as the mini grant awardees to showcase their work, and I hope we will be able to provide more platforms like these. The research that was presented really reflects the depth of expertise actually in the region that sometimes goes unnoticed or because it's not being disseminated. But honestly, the research shows the dedication of so many of you to generate evidence that can hopefully, and it will, shape policies and improve public health outcomes. And even if this was a virtual symposium, I think the engagement of everyone was inspiring, whether it was through presenting or facilitating or simply participating in the Q&A. And I thank you for enriching this event. Finally, I just want to say that at MFNet, we really are committed to supporting initiatives that bridge research with practice. I encourage everyone to really continue these conversations beyond today and explore opportunities for collaboration and ensure that all the valuable findings shared here can be translated into meaningful action. Thank you once again for being part of this symposium. I look forward to future engagements, continued partnership, and really our collective effort to improve public health in the Eastern Mediterranean region and even beyond. I wish you all the success and good evening from Amman and good day to all. Thank you.
Thank you, Dr. Randa. Thank you all.
Thank you,
Wish you a
Randa.
good
Thank you.
evening.
Thank you for
Thank you.
everything.
Thank you.
Thank you very much.
Thank
Good
you
day.
so much.
Thanks a
Thank
lot.
you.